Good morning, everybody. Welcome to the NOACS 2016. My name's Paul Dorian. I'm a cardiologist here at St. Michael's Hospital at the University of Toronto with an interest in heart rhythm disturbances. Dr. Verma, unfortunately, is not able to be here this morning. He'll be here a little later on today. He's professor of surgery, also at the U of T, also working here at St. Michael's, and he and I have the privilege of co-chairing this program. So first of all, welcome. So with no further ado, if I may, to sort of set the scene for what you're going to hear later on today, let me try to give you a practical perspective. This is just very personal. I'd like to think that my approach, and I think many of my colleagues who see lots of patients with atrial fibrillation, we've evolved an approach which we think is largely evidence-based, but of course some of it is really personal style and our assembling the accumulated evidence on how to take care of patients. So what I'd like to share with you in the next sort of 20 minutes or so is what I actually say to patients when what my mental checklist is and how I interact with patients when they have atrial fibrillation. And I've evolved a pattern, I don't want to call it a recipe because it changes obviously from patient to patient, but a mental checklist of what I do when I see patients with atrial fibrillation that I'd like to share with you. It is my opinion that it is very useful for all of us as caregivers when we see a patient with a particular disorder or disease, if we have a mental checklist. That way we are less likely to forget items, and then it's a little bit rehearsed, but that means we're less likely to sort of overlook things. And this is true in all complex fields. Pilots have checklists, as you know, because even though they may be expert and have flown the plane thousands of times, there's details that they may forget from time to time. So in that kind of context, what is my mental checklist? And we'll go over that. I do have some relationships to disclose with the pharma colleagues and partners that support this program. We have received support from this, and I will be very careful not to keep the talk free of bias as much as possible. So my objectives are asking all of us to think like a pilot. We'll explain what this means in a minute. I'm going to explain why I think medicine is like classical music, and while you boil the water and add the macaroni first before you add the cheese, because if you put the cheese in and then the water and boil it and then add the macaroni, it's going to look pretty sloppy. Just think about that for a second. It kind of sounds pretty horrible, right? So what do I do when I see a patient with atrial fibrillation, or more particularly in my subspecialty practice when I get referred a patient with atrial fibrillation? The first question I ask myself is, has the atrial fibrillation been documented? And I'll try to give examples of what I mean as we go along. So this is my kind of mental checklist. And the reason I think step number one is important is that there are at least some patients who will be labeled as having atrial fibrillation who don't have atrial fibrillation. And these are individuals most commonly who have a Holter monitor ordered for some particular purpose where they have a 5 or 10 or 12 beat run of what we call non-sustained irregular atrial tachycardia. Now this is ubiquitous. If we Holtered all of us in this room, probably 20% of us on any given day would have occasional episodes of 1-2 seconds of an irregular atrial tachycardia, and sometimes this is interpreted on a Holter monitor in the diagnosis bar as brief runs of atrial fibrillation. Of course, you as the caregiver don't know if a brief run is 2 seconds or 2 minutes or 2 hours. There's a big difference. And so you want to make sure that when the patient is labeled as having AFib, that it's truly AFib. By definition, we mostly mean at least 30 seconds of continuous atrial fibrillation with no P waves or no atrial activity recognizable on the ECG. Similarly, there's a big distinction between atrial flutter and atrial fibrillation. Atrial flutter, according to Canadian guidelines and in our daily practice, is a much easier rhythm to treat than fibrillation because it's amenable to radiofrequency ablation. So classical atrial flutter with a sawtooth P waves in the inferior leads, patients usually come with a heart rate of 150 or 100 because atrium's going at 300 a minute, the ventricles go 150 or 100 a minute usually. Those kinds of patients can be, I use the word, I think, carefully here, cured with a radiofrequency ablation with very low risk of recurrence, and it's a relatively straightforward procedure. Quite different from ablation for atrial fibrillation, which is a much more complex procedure, not universally successful, and we'll hear more about that later on today. The second question I ask myself, and this is really important, are there symptoms associated with atrial fibrillation? The reason this is important is that there are really two reasons, in my opinion, two primary reasons to treat atrial fibrillation. The first and foremost is to improve patients' quality of life. Atrial fibrillation is often symptomatic. Patients feel lousy, they have palpitations, lightheadedness, dyspnea, dizziness, exercise intolerance, and that's what we want to treat. They also are at potential risk of stroke. We'll come back to that, and that we can prevent with, or largely mitigate with anticoagulants. And stroke prevention is really unrelated to symptoms. But we have to remember that lots of patients are fatigue and dyspnea for different reasons. If you have a patient who's a smoker and has chronic lung disease, and they're short of breath on exercise, and they also happen to have atrial fibrillation, and now you put them on a large dose of beta blocker to control their rate, if their dyspnea was caused by COPD, you're not going to make them better. You might make them worse. So it's very important for us to understand what the symptoms are that are specifically caused by the atrial fibrillation as opposed to other comorbid conditions like heart failure, like diabetes, like obstructive lung disease, like deconditioning, sleep apnea, we'll talk about that in a minute, and so on. The third question I ask myself is, what is the pattern of atrial fibrillation? And this involves a bit of a discussion with patients. So patients frequently will tell you, particularly in the first few years of their disease, this is particularly true in younger patients, let's say in their 50s or 60s, they'll say, Doc, I get these rapid irregular palpitations, I'm short of breath, and it lasts an hour or 2 or 3, and then it stops. And this happens repeatedly. Now, if they're unlucky enough to go to hospital in the midst of one of these 2 or 3 hour episodes, if they're unlucky enough, what happens, because they don't need to go to hospital, because acute atrial fibrillation is not a life-threatening emergency. Myocardial infarction or heart failure or sudden death is extremely rare in acute atrial fibrillation. It's like migraines. It's unpleasant and undesirable, but not life-threatening. So patients unlucky enough to go to the emergency room, unless, of course, they have angina and heart failure, we need to be sensible. What happens is that the emerge doc will say, aha, you've got AFib, we need to cardiovert you, we need to give you intravenous, whatever they give, strychnine, castor oil, oil of Olay, whatever they give them, and the atrial fibrillation will stop. But it would have stopped anyway, even if they received no treatment. Now the patient believes, and the doctor believes incorrectly, understandably, but incorrectly, that this treatment was required to stop the episode. We know from large placebo-controlled, blinded, randomized trials of antiarrhythmic therapy in the emergency room that about 75% of all episodes of AFib in the emergency room will stop on their own with placebo. So usually it's a self-limiting disorder. So I tell patients, when you have AFib, chill, put on your Netflix, watch an episode of The Crown, watch whatever you want, have a drink, have a coffee, relax. And if in 6 to 12 hours you still have palpitation and you feel terrible, then think about going to hospital. If the patient's unbelievably unlucky, they're in West Palm Beach or in Los Angeles, then they go to Emerge and it'll cost them $50,000 on the average. Just believe me the number. The average emergency room visit for AFib in Florida or California, where I have some knowledge, is about $50K. Because they're going to get all kinds of tests they don't need, all kinds of investigations they don't need, some treatments they don't need, in order for this arrhythmia, which was going to stop anyway, to be stopped under observation. So when I see a patient with atrial fibrillation, and I know it's paroxysmal, meaning the patient has told me, excuse me, that the arrhythmia is going to stop on its own, I tell them, don't go to hospital unless you have crushing chest pain or you're dizzy or you're fainting. You have to be reasonable until some time has passed, usually about 12 hours, and then you might think about going to hospital. And that way you can avoid a lot of heartache, literally and figuratively. And then I ask myself, with the patient, are there treatable, reversible causes? And we'll talk about that in a bit of detail. The most common things are undertreated hypertension, sleep apnea, and alcohol in excess, not in ordinary amounts. An alcoholic, by the way, is somebody who drinks more than I do, which is pretty hard. But alcohol in moderate amounts is rarely a culprit, but in excess certainly can be a culprit. So this is a bit of a repeat, sort of more detail of what we talked about in my systematic approach. I not only want to know about symptoms, but it's very important for me to know how much the symptoms affect quality of life, and I'll give you some scenarios. I have a patient in my practice who has atrial fibrillation 2 or 3 times a year, lasting about 6 to 12 hours. During that time, it's a man, he is moderately disabled, he's lightheaded, he's dizzy, he's got palpitations, his heart rate's about 130, he's got a structurally normal heart, he knows it's not going to kill him, but he's completely discombobulated, he thinks he's going to die, even though he's been told, and he understands intellectually but not emotionally, it's like fear of snakes. He can't help himself, and as a consequence, he doesn't travel, he doesn't get on airplanes because he might have an attack on an airplane, he doesn't go south of the border, he doesn't go to South America or Europe, places he'd like to go because he's afraid there's no medical care. His life, he doesn't go on cruises, which he'd like to go on, so his life is basically constrained. He's now treated, so it's not so bad anymore, but initially his life was constrained because infrequent short symptoms, relatively speaking, had a dramatic effect on his quality of life. Conversely, you have other patients who are in atrial fibrillation 24/7 and are unaware of it. You don't have to treat those individuals because they're going to be just fine. They are just feeling just fine. So what's important is not so much the cosmetic appearance of the ECG or the Holter. What's important is the patient's symptoms related to the arrhythmia. And this is, of course, reflected in the Canadian guidelines. Along with that, we asked them, how invested are you in taking antiarrhythmic medications and having an ablation or various kinds of treatments, which are primarily for the purposes of improving your quality of life. They each have risks and benefits, and we need to understand, so we don't tell patients, Mr. Smith, Mrs. Jones, you need treatment X. We say, Mr. Smith, Mrs. Jones, we have these treatments available. These are the consequences, these are the risks, these are the benefits. Let's together, in a shared decision-making model, figure out what you think is the best for you. Now, self-management is the sort of third piece that patients often ask about when they go on the internet. Many of them come away with the idea that exercise will kill them, coffee will kill them, alcohol will kill them, and strokes will kill them. We'll talk about strokes in a minute. I spent at least 5 minutes of the conversation. I have the luxury of being able to do that, to tell patients that coffee is not contraindicated in atrial fibrillation. There's a meta-analysis published in the Canadian Journal of Cardiology about 1.5 years ago. The accumulated evidence suggests that coffee, if anything, prevents atrial fibrillation. I'll repeat that. If anything, caffeine prevents atrial fibrillation. There's not a hint of evidence that caffeine increases the duration or severity of episodes of AFib. Yes, caffeine, if you have too much, will make you feel anxious and have palpitations, but that's got nothing to do with AFib. So I tell them to drink as much coffee as they want, and they're very happy with that. I tell them that stress doesn't cause AFib. It may not be desirable. If you argue with your spouse and it's stressful, then that's a problem, but it's not going to make your AFib worse. That may be a relief, at least to some patients. Exercise does not cause atrial fibrillation. We'll talk about sports cardiology later today, but for 99.99% of your patients, recreational exercise prevents atrial fibrillation. Rare patients have exercise-induced AFib, but it's uncommon, and they'll tell you. But for most patients, a program of regular exercise is, from an epidemiologic perspective, preventative. People who exercise regularly are less likely to get AFib than individuals who are sedentary. And so exercise is permitted. There's now programs, some very well-known ones, that seek to get patients with atrial fibrillation, even with heart failure or other consequences, to get on an exercise program, and their quality of life improves, even if their AFib doesn't necessarily go away. As I said, I tell my patients not to go to the emergency room unless they absolutely have to if they have atrial fibrillation. Atrial fib doesn't cause myocardial infarction, it doesn't cause sudden death, and so on. And we talk about alcohol. There is evidence that alcohol promotes AFib in excess. From data from Scandinavia, this is for men, more than 4 or 5 standard drinks a day. That's a lot of alcohol. And for women, more than 2 or 3 standard drinks a day. So having 1 or 2 glasses of wine or 1 drink or 2 drinks a day, even if a patient drinks every day, is not known to promote atrial fib. Conversely, of course, if you have a glass of wine every day with dinner, that's very different from having 7 glasses of wine on a Saturday. That does promote atrial fibrillation. So I tell my patients to try to keep the amounts moderate on any given occasion. And then the last piece is we have to consider as caregivers, given all of this understanding of quality of life and that we've had a conversation with the patients, we now have to ask ourselves, do we go primarily with the strategy of rate control, which implies that we're not going to attempt to get the sinus rhythm restored or maintained, but some patients do very well with rate control therapy, in other words, drugs to affect the AV node, which will slow the ventricular response, calcium channel blockers, long-acting diltiazem, or beta blockers. Those are the ones most commonly used. We use digoxin very infrequently now. It's kind of been de-emphasized in the Canadian guidelines. And we talk to the patients about the hierarchy. The most important part of this slide is I try to explain to patients that there's no one single best recipe for chocolate cake. We're going to see which one works the best for them, and their tastes may change over time. It's the metaphor that I use. So today we'll start with plan A, which is usually rate control, a calcium channel blocker, sometimes a beta blocker. If they don't feel well, if there's a problem, what I tell the patients, this is what I tell them, this is me talking to the patient, you will tell me when it's time to move on to plan B. I'm not going to tell you. You will tell me, I don't feel good, I'm still short of breath, I'm still having attacks, my quality of life is not as good as I would like it to be. It's time to move on to plan B. So I don't tell the patients what to do. They tell me what to do after they've been educated. And typically plan B is some strategy to maintain sinus rhythm, either intermittent or continuous antiarrhythmic drugs. And then plan C is either more drugs or radiofrequency ablation, depending on the patient. And we'll have a chance later on today to explore some of those nuances. How do we semi-quantify all of this? This is a little bit of background to, in the next sort of 5 minutes, a little bit of background to what we've been talking about. The Canadian Cardiovascular Society has published an AF severity scale. This is very analogous to the New York Heart Association functional class. This is just a shorthand way of writing in your chart or you in your mind saying how much is the condition affecting the patient's quality of life. And this is the condition and its treatment. So if you have a patient who's got atrial fibrillation and a heart rate of 105, and they're aware of palpitations, and now you give them a beta blocker to slow down the heart rate, if their palpitations go away, but now their heart rate is 60 and still in AFib, that's good. But now if they can't sleep, and if they're fatigued, and if they're dizzy, and they're lightheaded, and they feel awful because of beta blocker adverse effects, you haven't done them a favor. Remember, this is not a life-threatening condition. So that we have to not only consider the effects of the disease or the rhythm, we have to consider the effects of the treatment. So the score is designed not so much to look at the atrial fib by itself, but the general condition. As I said, my patient who has atrial fibrillation 3 times a year for 6 hours, from an aerial view, you might say, well, that's not a big deal. That's a minimal burden of atrial fibrillation. But for that patient, they may be in a CCF class 3. Because it has this particular patient of mine, this limited amount of AFib has a major effect on his quality of life. So we have to always think of the patient here, not so much the rhythm. And it's just a way of having a shorthand. So if I write in my chart, patient is in SAF class 3, I know that they're not happy and that I'm going to want to do something to try to get them to feel better. So this is kind of a summary. Once you detect atrial fibrillation, you want to treat the underlying cause in the top right. This is directly from the Canadian guidelines. And you separately want to think about, we'll hear lots about stroke prevention today. Just to remind ourselves, the stroke prevention chapter is a separate chapter from the management of the arrhythmia chapter. This is because patients can be completely asymptomatic, be unaware of being in AFib, but still be at high risk of stroke. In a 75-year-old hypertensive diabetic, let's say with AFib, who's just not even aware of it. Conversely, if you have a 45-year-old perfectly healthy patient otherwise with atrial fibrillation, they may be extremely symptomatic, but their stroke risk is low, and they don't need any form, according to guidelines, of stroke prevention. So the two are sort of separate concepts, and I think it behooves us to think totally separately, sequentially. Question 1 is, how do I manage the arrhythmia together with the patient? Question number 2 is, what is the stroke risk, and what do I do to mitigate the stroke risk? And we'll talk, obviously, in great detail. So that, why do patients get AFib? Well, I think I show this slide not so much because of the pathophysiology, but to remember what conditions are most commonly associated. I think about obesity is not difficult to diagnose, often an underlying cause. Sleep apnea, often an underlying cause and overlooked. But in 80% of your patients with AFib, they'll have hypertension with or without heart failure. All of these conditions lead to atrial inflammation or fibrosis. There's a small sliver of patients who may have familial or ion channel related AFib. That's a really minor cause. Most of your patients with AFib will have one of these or more of these conditions. Valvular disease, of course, can cause atrial fibrillation, but it's decreasingly common, if you like, at least in North American populations, very different in less developed countries where you have rheumatic disease and other forms of valvular disease that cause atrial fibrillation. So what can you do for your patients? And I'm not going to so much talk about antiarrhythmic drugs. First, you can get them to lose weight. This is obviously a big ticket and a difficult item, but this is work done from Prash Sanders' group in Adelaide, Australia. What they showed is when you randomize patients with AFib who are overweight and lose on the average 10 to 15% of their body weight, in kilogram terms, most of them are about 100 to 120 kilos. They lose somewhere between 10, 15 kilos, that's about 30 pounds. So they don't have to necessarily get back to normal weight, but when they're able to lose weight as part of an exercise and weight loss regimen, they have a dramatic reduction. It's a little hard to see from the back. The number of episodes goes from about 3 per month to 0.62, so a dramatic reduction in the number of episodes, but more importantly, a dramatic improvement in quality of life from AFib as a consequence of weight loss and some degree of exercise. And so this is something we should advocate to all of our patients. It's an opportunity to tell your patients who are obese or overweight, Mr. Smith, Mrs. Jones, you have AFib. You can make yourself better if you lose weight, and exercise may be part of that sort of treatment paradigm. Something that is often observed, and there's some evidence, we don't have time to go over it in great detail, that most of our patients with atrial fibrillation are diagnosed as hypertensive. Remember, 80% of them will have hypertension. This is in almost all series and studies. But about a third to a half of the patients with hypertension will be undertreated. We now have some evidence from the SPRINT study and others that it behooves us to be more aggressive with blood pressure lowering than we used to be. This is not completely proven, but it is my belief that it is in the patient's best interest for us to be particularly vigilant about hypertension treatment in AFib patients. Have to be vigilant in everybody, but atrial fibrillation, think of it as end organ damage from, atrial fibrillation is end organ damage from hypertension, just like kidney disease and retinal disease is end organ damage from diabetes, and that's a signal that we need to be aggressive with blood pressure. And I try to get the blood pressure in the office to 130 systolic at least, and home blood pressures, you want to get them down to sort of 125 systolic if you can, by intensifying blood pressure measurement. So I wouldn't just sort of pass off isolated blood pressure measurement in the office of 140/90 and say, yeah, you know, that's good enough, just stay on your medications. I would think about intensifying medications. We talked about obesity and sleep apnea. Sleep apnea commonly overlooked, a common cofactor in this profile of patients who have atrial fibrillation, and patients feel better when they go on CPAP if that's indicated, and their atrial fibrillation probably gets better, although that's not totally proven in randomized trials. The rare patient you have in your office, and we'll talk about that later in detail, who is a serious triathlete or an Ironman athlete, this is one patient in 1,000 or less, they may have atrial fibrillation as a consequence of endurance exercise, but this is pretty uncommon. And we talked about episodic alcohol excess. So this is just to remind us, this is from a study looking at quality of life. Quality of life is impaired in patients with AFib. I think we can sort of believe that. The Canadian guidelines remind us. A lot of this is now just a repeat of what I've been talking about, so my apologies, I'm going to go pretty quickly here. This is just to reinforce what we've talked about. Canadian guidelines remind us to identify the structural heart disease, first relieve symptoms, improve quality of life, and then worry about some rare consequences of AFib like tachycardia-induced cardiomyopathy, reduce emergency room visits. This is what the Canadian guidelines recommend, and of course, this is what we should be striving for. And then, as we'll talk about in some detail over the next several hours, prevent stroke and systemic embolism. Those are the goals. You don't have to remember this is all in the guidelines, just to remind us that you can start with you can think about an algorithm. Again, I don't want to belabor this. This is from the 2014 update, of the guidelines, but it's the same in 2016. Dr. Verma and Dr. Talajek were part of the committee. Dr. Verma was the chair of the committee. Basically, this reminds us that you can develop an algorithm to stepwise take yourself with the patient through a process of deciding what to do in a patient with AFib, starting with rate control. If it doesn't work, then think about cardioversion and rhythm control. This is all the rate and rhythm portion of the guidelines. The stroke prevention portion we'll talk about in some detail, but here's the stroke prevention portion. The primary thing to remember in this slide, there's only one thing to remember, is if the patient's over 65, oral anticoagulation is indicated. There's going to be rare contraindications. So yes, we recommend measuring the risk factors, CHADS and CHADS-VASc, but the sort of Canadian approach is to simplify for the purposes of bedside or in the office approach. The simple approach is the patient over 65? If yes, oral anticoagulant indicated, end of story, unless there's some major contraindication. So we look at these other risk factors, but just think about that as the primary and usually only step you have to take, because the majority of your patients will be over 65. Patients over 65, you don't have to necessarily, you have to think about these other factors like diabetes, hypertension, heart failure, prior stroke, but you've already made your decision that anticoagulation is indicated. So what do? Well, we use anticoagulants in order to prevent stroke and prevent death from stroke. Warfarin's a fantastic drug. We think, and the guidelines assert, and I think, that there are better treatments available than warfarin, but we have to remember that when we compare the newer anticoagulants, you all know this, but it's worth recalling once again, that when we compare the new anticoagulants to warfarin, we're not comparing them to nothing. We're comparing them to very effective treatment. Warfarin is very effective at preventing stroke and death in patients with atrial fibrillation. Maybe we can do better, but warfarin is a very good drug indeed. But in practice, warfarin is not as good as in theory. As Yogi Berra, he said lots of very smart things, including it's not over until the fat lady sings, which means I have to get off the stage very soon. But warfarin has problems. We don't have to belabor this. In the short run, warfarin can increase stroke rates. Physicians, at least for the last 15 years or so, don't like to use warfarin. Many of them stop it because of complications or difficulties in the management of warfarin. In the first 30 days, this is on the y-axis, the instantaneous risk of bleeding as a function of time from when warfarin is started. And in the first month of warfarin therapy, it's about an absolute 1% risk of major hemorrhage, or an annualized risk of about 12%. So starting warfarin is a big deal. Patients already on warfarin and they're very stable, the risks are a lot smaller. But if you're about to write a prescription for warfarin for the first time, we've done this for decades, but we have to remember that that's not a straightforward exercise in terms of risk. So what questions do I ask myself about stroke prevention? And we'll come back to this theme with many other speakers, and I apologize only halfway for being repetitive, but I think we need to emphasize this. Most patients who require stroke prevention, this can safely be started, but there's questions you ask yourself which relate both to the risk of bleeding, but primarily to the general management of the patients, particularly to their renal function. So when I ask myself, should I use an anticoagulant? If so, which kind? What do I have to pay attention to? I need to know whether they have diabetes or heart failure, because these things are associated with kidney dysfunction. I want to know if they have mitral stenosis or a prosthetic valve, in which case warfarin is indicated and the novel anticoagulants are contraindicated. We need to know the renal function. If the hemoglobin's already low, the patients may be bleeding. We need to think about that. We need to know about prior bleeding history, and we need to figure out if the patients are going to actually take their drug as prescribed. Do they have the cognitive function, the means to take the drugs as prescribed? And then we have to talk about patient values and preferences. So these are the kinds of things we need to discuss with patients and ask ourselves before we write that first prescription or the renewal for an anticoagulant treatment. And we'll talk about these themes in some detail. So the bottom line is, I'm just going to leave this up for a second and then stop. We've distilled this. Noah Ivers is a family physician at the University of Toronto, and I, as a companion to the guidelines, we've kind of taken everything I've just told you and put it into this manuscript, which is available. It was published in sort of as a companion to the guidelines in 2014, and it's a kind of a stepwise, maybe ridiculously simplified, but simplified approach to how we deal with the CCS recommendations for the management of patients with atrial fibrillation. So just to repeat briefly, why does a patient have AFib? What is the quality of life related to the atrial fibrillation and its treatment? Separately, and what am I going to do about that? Separately, what is the stroke and bleeding risk, and deal with that? And then lastly, what is the follow-up strategy, which is more of an issue for tertiary care, but even in primary care, you want to know how often do you want to see the patient? How is the patient doing? If they're doing badly, you want to see them sooner. If they're doing very well, you may not need to see them for a while. And then last of all, if the patient is still symptomatic and they're not happy, that is the time that you may want to think, for those of you that are primary care practitioners or even specialists, that you think the patient may be eligible for some therapies that are available in arrhythmia specialty care, like radiofrequency ablation, for example. That's the time you may want to think about a referral. And with that, I'll stop. Thank you very much. Dr. Verma is director of the Heart Rhythm Program at Southlake. He's a co-chair of the Canadian Cardiovascular Guidelines, and nobody's better equipped than he to tell us about the thinking that you might want to go through when your patient is on warfarin and you're thinking about switching them to a novel anticoagulant. Atul, thank you.
Thank you very much. So basically what I'm going to be talking to you about today is when and if you should be switching your patients who are on warfarin to a novel oral anticoagulant. And these are my disclosures for the talk. So as you know, there's a little bit of a tension in practice and in guidelines. So the Canadian guidelines, as Paul showed you on the previous slides, suggests that if you're going to choose an oral anticoagulant for your patient who has non-valvular atrial fibrillation, that you should choose in preference a NOAC over warfarin. And yet, if you look at the government policy in Ontario and most provinces across the country, the LU code that you write in order to approve payment of the NOAC says that you first have to fail warfarin before you're allowed to use the NOAC. So you have guidelines suggesting that you should be using NOACs as kind of first line in preference, but you have public policy that is saying that you really should try warfarin first. And then that leads to the next question, well, what if I have a patient who is stable on warfarin? What exactly should I be doing with that patient? Should I just be keeping them on warfarin? Or should I perhaps be offering them the chance to switch, knowing some of these issues that I've just talked about? So I think first and foremost, we have to understand that there are some patients in 2016 who still need to be on warfarin. So in other words, NOACs cannot replace every single circumstance where a patient is on oral anticoagulation. And for the most part, remember that all of the NOACs were used in patients with non-valvular atrial fibrillation. And the official definition of non-valvular atrial fibrillation are patients who either do not have a prosthetic valve, either metallic or bioprosthetic, patients who do not have rheumatic valvular disease, and patients who have never had a prior mitral valve repair. Now, I think for rheumatic valvular disease and a mechanical valve, that certainly makes sense that those patients should always be on warfarin and they cannot take a NOAC. There have been trials, clinical trial evidence, for example, with dabigatran, that has attempted to use NOACs in patients with mechanical valves, and to make a long story short, it didn't work. There was an increased risk of valve thrombosis, there was an increased risk of stroke, so you should never be using a NOAC in a patient with a mechanical prosthetic valve. What about bioprosthetic valves? Because we know that once a bioprosthetic valve is mature, we don't normally orally anticoagulate those patients. And this is a little bit more controversial. In fact, this was discussed at the guideline panel, and most of the members of the guideline panel felt very comfortable using a NOAC, even in the presence of a mature bioprosthetic valve. And in fact, there have now been two recent publications, one from the ENGAGE group, Bob Giuliano is one of the authors, and another recently published in the Journal of the American Heart Association, suggesting that patients with bioprosthetic valves may in fact be perfectly safe on a NOAC. Mitral valve repair is also a little bit controversial because, again, for most mitral valve repairs, we don't normally continue them on chronic oral anticoagulation. So if they start to develop atrial fibrillation, it may in fact be reasonable to use a NOAC, but there's just a lack of evidence to guide us on that. So why on earth would you switch a patient who is on supposedly stable vitamin K antagonism to a NOAC? Well, some of the reasons may be that vitamin K antagonism is never really stable. We all can remember patients in our practice who repetitively come to us and their INRs every month or every couple of weeks are consistently in the therapeutic range. And then all of a sudden, 2 years into this, you get an INR that's suddenly 7.9. And you ask the patient, well, did you change your diet? Did you take an antibiotic? Did you change your drugs? And you really can't figure out anything that is obvious for changing that INR so dramatically. The other potential argument would be a reduction in fatal bleeding events with the NOACS versus vitamin K antagonism, and I'll talk a little bit about that. It may be a physician preference. So for example, if you're in a very, very busy practice and INRs are piling up on your desk, and that's probably your least desirable part of the week when you have to go through all the lab tests and phone the patients at home to tell them what to do with their Coumadin, you may have particular physicians who say, you know, I've had enough of this, I'm going to switch my patients to the NOACs. And it also may be a patient preference issue. So the patient who's chronically on warfarin may come into your office and say, you know what, I've seen these ads on American television about these new oral anticoagulants, and I'm just wondering if it may be an option for me. Now, one of the questions is, does stable warfarin exist? And as I already mentioned to you, there are many patients who are stable on warfarin, but will encounter variation in their INR at some point in time, particularly those patients who are not followed in an anticoagulation clinic. And we know that the vast majority of patients who are on warfarin are not followed in a formal anticoagulation clinic. We know that dietary changes, drug or supplement interactions, and this is an important point because oftentimes when the INR will vary and you look at their prescription drug list and you see that nothing has changed, make sure you ask the patient about other nutritional supplements that they may be taking. Lots of patients are taking herbal therapies, over-the-counter therapies, all of which may potentially be interacting with warfarin. A change in health status, so if the patient suddenly becomes hospitalized and they become dehydrated or malnourished as a result of that, there may be fluctuations in their INR. Some of the changes may just occur spontaneously without any recollection of any obvious triggering change. Now, the best TTRs, or the times in therapeutic range, are usually obtained in clinical trials. And even in well-designed clinical trials, we see TTRs of about 55 to 65%. So if you look at the major NOAC trials, that was about the range of the time in therapeutic range. And it seems to be that even in that ideal setting, that's about as good as it gets. Real-life TTRs can often be much lower. But also keep in mind that a time in therapeutic range is a mathematical calculation, which is basically like taking an average of all of the INRs that you have. So for example, if you decide that you're only going to measure the INR on your warfarin patient twice a year, and it happens that on both those occasions they're in the therapeutic range, then theoretically their TTR is 100%. And you can say, look, I have perfect warfarin management. But what would that TTR have looked like if you had measured that patient's INR on a monthly basis, or on a biweekly basis, or potentially even on a daily basis, now that some patients have their own home monitoring kits and they can begin to monitor their INRs at home. So sometimes when we see very high TTRs reported in the literature, or for certain country experiences, also ask yourself, how often is the INR really being managed? Now, this is just one example of the Orbit AF registry. This is US data that comes from about 5,200 patients at 155 different sites. And keep in mind that this registry was funded by the NOAC companies. But I think it gives a fairly reasonable snapshot of the current practice of INR treatment, at least in the United States. And you can see here that about 68% percent of the patients were in the therapeutic range at any given point in time. About 10% of the time, these patients would end up above the therapeutic range, and about 17% of the time, the patients would end up below the therapeutic range. And again, when you look at that number, you think, well, you know, you said those clinical trials were giving us about 55 to 65% time in the therapeutic range. So if this is real life, then actually we're not doing too badly. However, having said that, look at the extreme variation in the mean number of days between INR testing. And what's particularly concerning is that when you look at patients who had INRs greater than 3, where you would think that you would want those patients to get a repeat INR within a fairly short period of time to make sure that you're bringing them back into the therapeutic range, look at the variation here, where you have patients even with INRs between 5 and 6 waiting, you know, more than 10 days before they get their next INR reading. So again, going back to that argument about the frequency of INR monitoring, if you're only monitoring it every 25 days or potentially even less frequently, you can make your time in the therapeutic range look a little bit better. If we look at the data from this registry, perhaps what is a little bit concerning is that patients with higher CHADS-VAS scores, or the atria scores, and the atria score is just another way of calculating stroke risk. What's a little bit concerning here is that the time in therapeutic range is actually a little bit less in those patients who are at highest risk of events. And that is actually counterintuitive, because if anything, you would want to make sure that those higher risk patients are being better protected, not less protected. But when you think about it, it kind of makes sense, because who are those high-risk patients? Those high-risk patients generally are elderly patients with multiple comorbidities, and you can imagine that those patients may have more difficult access to getting frequent INR monitoring. Maybe they're dependent on a loved one or a relative to drive them out to the lab to get their INR checked. Maybe those patients are in and out of hospital all the time with frequent exacerbations of chronic illnesses, which may change their nutritional status, which in turn can lead to fluctuations in their INR. So perhaps it's not surprising that the highest risk patients have a lesser time in the therapeutic range, but it's certainly concerning given the fact that those are the patients who can most benefit from a better TTR, not from a worse TTR. This is more data from the TREAT-AF study, which was a very, very large study in the VA medical system, also in the United States. So here we had nearly 168,000 patients that were studied, so certainly a very, very large data set. And again, when you look at the time out of the therapeutic INR range, what's a little bit concerning again is if you look at the long-term TTR, or the long-term time below the therapeutic range, or the long-term time above the therapeutic range, what you see again is this trend that in those higher risk patients, you start to see a drop-off in the time in the therapeutic range. And if anything, you start to see an increase in the time below the therapeutic range, and in terms of the time above the therapeutic range, there doesn't seem to be very much of a difference there. This is a slide of the HAS-BLED score. So the point that's being made in this slide is that the HAS-BLED score is a measure of bleeding risk. So again, for those patients who are at highest risk of bleeding with a high CHADS-VAS score, you would hope that they are less frequently above the therapeutic range and are more frequently within the therapeutic range, because these are the patients who are most likely to bleed. But again, you start to see a trend that in those highest risk patients with high HAS-BLED scores, the time in the therapeutic range starts to drop off. And then this is the slide that shows the risk by CHADS-VAS score, and again showing that the higher risk patients for stroke are dropping out of the therapeutic range more often than the lowest risk patients. And again, this is counterintuitive. This is ideally not what we want to be having happen to our patients, but it's certainly understandable when you think about the patient profile of who those high-risk patients might be. Now, NOACs potentially do have advantages over vitamin K antagonists. So all of the NOAC trials did show a consistent reduction in fatal bleeding and intracranial hemorrhage versus vitamin K antagonism. And in fact, this is probably the strongest reason why the CCS Guidelines Committee suggested that they would prefer to treat patients with NOACs over vitamin K antagonism. Because when you look at the actual stroke rates, most of these agents were in fact non-inferior or equivalent to warfarin in terms of preventing stroke. But it's really the benefit on the fatal bleeding side that is potentially offering substantial benefits over vitamin K antagonism for your most of your patients. There is also a consistent trend, and I will repeat trend, it wasn't statistically significant in most of the trials, towards reduced mortality in all of the NOACs trials versus vitamin K antagonism. And this may in part be driven by the reduction in fatal bleeding and or other cardiovascular outcomes. And the question then becomes, should we be denying our chronic vitamin K antagonist patients these potential benefits and not offering them the chance to switch? So these are forest plots that basically summarize all of the data from the 4 major landmark clinical trials of the NOACs versus warfarin. And if you look at stroke or systemic embolism, you'll see that in most of the trials, there may have been a slight trend towards benefits of the NOACs over warfarin, but the confidence intervals also cross 1. So in terms of stroke prevention, for the most part, NOACs may offer a slight benefit over vitamin K antagonists, but for the most part, they were non-inferior. But it's really when you start to look at major bleeding events, and particularly the fatal bleeding events and the occurrence of intracranial hemorrhage, where you see the benefits of the NOACs over vitamin K antagonists. And you can see here that there's a much more consistent trend to fewer events in the NOAC arm versus warfarin. And as I mentioned, what's very interesting is that there's a very consistent trend towards decreased mortality in the patients on NOACs versus warfarin. And so when your patient who's on chronic warfarin, even if they do have a fairly good TTR comes in, you always have to ask yourself the question, well, are there potential benefits to switching this patient to a NOAC? More data that's important is that all of the trials compared patients who were naive to warfarin versus those patients who came into the clinical trial already on warfarin. And they looked to see whether the benefits realized in the trial were consistent amongst those patients who were either naive to warfarin or who already came into the trial on warfarin. So this is data from the RELY trial, which, as you know, was using dabigatran. And what they showed is that if you look at the overall result in the trial of dabigatran 110 milligrams BID versus warfarin, the patients who were already warfarin experienced the same relative risk benefit versus warfarin compared to those patients who were warfarin naive. And we see exactly the same thing in the dabigatran 150 milligrams BID arm versus warfarin, where the relative risk reduction was similar in those patients who already came into the trial on warfarin versus those patients who were warfarin naive. So in other words, what that suggests is that even for those patients who have been on warfarin, they've been through that initial phase where Paul showed that there may be an increased risk of bleeding, they perhaps have fairly stable TTRs, that even in those patients, the same benefits could be realized. And if we look at all of the trials in terms of time and therapeutic range and the relative risk reduction in stroke, what's also very interesting is whether you look at the rivaroxaban study, the dabigatran study, or the apixaban study, we can see here that regardless of the TTR group, whether that patient was in the lowest quartile, second lowest quartile, or highest quartile of TTR, that the relative risk reduction of the NOAC versus vitamin K antagonist was consistent across all of the TTRs. So again, that evidence would suggest that even in the well-managed warfarin patient who has a very, very good TTR, we may still expect to see the same relative risk reduction or benefit of NOAC versus warfarin. Now, as I mentioned, there may be physician preferences that are driving this. So if a patient has particularly a difficult time achieving a stable TTR, then a NOAC may be actively recommended by their physician so that they're not having to struggle with trying to get these patients into the therapeutic range. And as I mentioned, following INRs can be very, very challenging in people's practices and may not be worth all of the time and the effort. As I said, there are patient preferences that may be driving this. So again, some patients simply don't like the inconvenience of INR monitoring, so they may in fact live right next door to Life Labs, and all they need to do is get up and go out and go to the Starbucks and then walk 2 blocks and go to the Life Labs, and yet even those patients will come back and say, I really hate doing this, every week or every month or every couple of weeks, regardless of how frequent that may be. Patients also may perceive NOACs as being more stable or safe, and vice versa. Some patients may also feel that NOACs are less stable or less safe based on some of the lawsuit ads that they see coming out of the United States. So you can certainly get all kinds of opinions across the spectrum of patients who are on chronic vitamin K antagonists. And then finally, another big patient preference for switching is often the dietary and supplement restrictions. So a lot of patients who come in on warfarin, even if they're well managed, dislike the fact that, in the summertime they can't binge on their garden vegetables and other things like that. And then in the wintertime, suddenly the vegetables go away and they're having to manage their dosing of warfarin accordingly. And they like the idea of being on a pill where they don't need to worry about their diet or how many vegetables that they're taking. Now, the antidote is an issue certainly for some physicians and for patients. So I certainly know a lot of physicians that said, I'm very reluctant to prescribe these NOACs because there's no antidote for the NOACs, and I'm concerned about what happens when my patient bleeds. And similarly, there are also patients who come in and say, what, doc, I'm kind of interested in switching, but at least I know with warfarin I have my antidote, and as a result, I'm comfortable with that and I don't want to switch. So this has been a barrier to some physicians and patients accepting a switch from vitamin K antagonist to NOAC. I think the important issue that we all need to remember is that whether you're on a vitamin K antagonist or a NOAC, the utility of an antidote is going to be very, very limited in your most severe bleeds, particularly in intracranial hemorrhage. A lot of people say that, once you've had an intracranial hemorrhage, the horse is out of the barn, and no matter how much antidote you give that patient, you're probably too late, and there's not a lot of difference that it's going to make. Plus, don't be fooled, because whether you're dealing with the new antidote, for example, for dabigatran, which is idursulfimab, or whether you're dealing with the traditional antidotes like PCC or vitamin K for warfarin, antidotes don't magically make the bleeding stop. So even in the REVERSE-AD trial, when they were assessing idursulfimab for dabigatran, the mean time to cessation of bleeding was still over 11 hours. So in other words, just because you give the antidote, it doesn't mean all the blood suddenly dries up and the patient magically goes back and gets discharged from hospital. The patient still has to undergo all of the surgical and intensive efforts, fluid replacement, blood replacement, surgery, et cetera, that you need to do in order to stabilize the bleeding. The argument of an antidote, whether for vitamin K antagonism or NOACs, I think is a little bit of a red herring in all this, because at the end of the day, the most serious of bleeds, when they happen, an antidote isn't necessarily going to benefit you one way or another. The other thing to remember is that PCC, which is a great antidote and a specific antidote for vitamin K antagonism, is also a pretty good partial antidote, at least for the factor Xa inhibitors and even the direct thrombin inhibitors. So even though we don't have a specific clinically approved antidote for the factor Xa inhibitors at this point in time, PCC is actually a reasonable alternative, and in those emergency situations, for those of you who are working in emergency departments, always remember that PCC is available to you. And just to reinforce this, here's an algorithm for bleeding management, and I know that bleeding management is going to be talked about, I think, in the next talk or later on in the afternoon, so I'm not going to belabor this point, but this is from the 2016 ESC guidelines. And it's a very nice algorithm just basically showing that for minor bleeds, you're basically going to be holding the NOAC for a day or two, but you're certainly not going to be giving an antidote. Even for the moderate to severe bleeds, you're probably not going to be giving an antidote either for warfarin or the NOAC, and you're going to be focusing on fluid replacement, blood transfusion, and treating the underlying cause. And it's really only in those very, very severe or life-threatening bleeding situations where you'd ever consider giving an antidote. And this is, in fact, the only situation where the antidote for dabigatran has been approved. And in the CCS guidelines in the 2016 update, we actually suggest that idursulfimab should only be used in those patients who are in those severe life-threatening situations. So antidotes are not going to address the nuisance nosebleeds. Antidotes are not going to address the nuisance hemorrhoidal bleeding. And don't think that antidotes are there in order to treat those particular causes of bleeding. Now, if you decide between the physician and the patient that you do want to switch from warfarin to a NOAC, how would you do that? So first of all, for any patient who is still on warfarin, I first screen to make sure that there are no absolute contraindications against switching. Predominantly the presence of a mechanical valve. Often patients can tell you that they've had valve surgery, but they may not be as specific about the type of valve that they had. A very good clue is simply to put your ear close to the patient's chest, and if you hear clicking, then they probably have a mechanical valve, and those are patients that you should absolutely not switch from vitamin K antagonist to NOAC. When a patient comes in and they don't have a mechanical valve, and perhaps they have non-valvular atrial fibrillation and they're on chronic warfarin, I always bring up the option with the patient. So I don't tell the patient, look, you absolutely have to switch from warfarin to a NOAC, but in case they're not aware, I do bring up the option to explain that there are newer drugs that are on the market now, that are available, that may be able to replace your vitamin K antagonist. I always listen to the patient. That's very, very important. So if the patient is telling you, look, I'm just not interested, then I don't have the conversation any further. Maybe I'll bring it up at a future time. But if they are interested, I'll usually provide them with further information. But as I said, some patients will not be interested in switching for whatever reason, and that's where you just have to end the conversation and bring it up at another time. If the patient is interested and they said, yep, I want off this warfarin stuff and I want to be on one of the NOACs, how would you actually go about switching? So in general, what I will do is I will stop the vitamin K antagonist for about 2 to 3 days before initiating the NOAC. Usually 2 days is enough as long as the INR is in a sort of low therapeutic range. If the last INR is kind of on the higher side, you may want to wait a little bit longer, for example, 3 or 4 days. Technically, if you look at the drug monographs for the NOACs, all of the companies say you should recheck the INR 2 or 3 days later before starting the patient on a NOAC. And to be perfectly honest, I do not routinely do this. So usually when the INR is in the therapeutic range, I'll usually tell the patient, stop it for 2 or 3 days, start the NOAC after that, and I'm not usually bringing the patient back to recheck the INR. Now, if the last INR was 7, then that's a scenario where I probably would not only wait longer, but probably recheck the INR before I start the patient on the NOAC. But for most patients, I don't think it's necessary to bring them back and recheck the INR. So I'll end off here, and I'll basically say that in conclusion, not all patients who are on vitamin K antagonists can be switched to NOACs, and you just have to remember who those patients are. And I'm going to emphasize, and I've probably said this now 3 or 4 times, but I'm going to say it for the 5th time, patients with mechanical prosthetic valves must remain on a vitamin K antagonist, and they cannot be switched to a NOAC. Rheumatic valvular disease probably should also continue on vitamin K antagonism until we have further data about the safety of using NOACs in those patients, and there are ongoing trials. I would say that most patients with non-valvular atrial fibrillation should at least be considered for the switch, and a discussion should be initiated taking into account both the physician and patient priorities, and listen to the patients when they express their preferences. And making the switch basically involves letting the vitamin K antagonist wear off prior to initiating the NOAC. Thank you very much.
Thank you very much, Atul. We'll have lots of time for questions for Dr. Verma's presentation, as well as Dr. Eichelboom, who's just stepped up to the front. So with no further ado, Dr. Eichelboom's Associate Professor of Medicine at McMaster. He's internationally known for his contributions to understanding the risks of bleeding with NOACs. He's published many papers, and there's probably nobody in the country or anywhere worldwide who is more expert on bleeding risks than John. So please take it away. Thank you.
Well, thank you so much, Paul. You're very generous in your comments, but really it's a pleasure to be here this morning, and it's a pleasure to speak on my favorite topic, which is bleeding. And we're doing a ton of research in this area. I think it's the one outcome event that we fear the most. It is perhaps the single most common outcome event in trials of antithrombotic therapy. And in those particular trials, I'd suggest to you it's one of the least well understood and researched. But the main message for today is we need to overcome our visceral, our innate, our sometimes irrational fear of bleeding and anticoagulate more Canadians with atrial fibrillation to prevent stroke, because that is ultimately our goal. And I think today in 2016, we have never been in such a good position to overcome our concerns about bleeding, because we have the safest possible yet antithrombotic therapies for stroke prevention in atrial fibrillation. Now, my disclosures are on this slide, and there are important disclosures here because I've worked with all of the pharmaceutical industry, but my most important disclosure relates to my working at an anticoagulation clinic. There are sometimes passionate arguments about whether one drug is better than another. The most passionate of those who say warfarin is the best still are those who run clinics, because we get $15 a month per patient if we run them through our clinic. And it's very cheap to run a clinic. You need a couple of people and a piece of software, and you can make a ton of money. So that is my biggest disclosure. Now, at the end of this program, I hope you'll better understand why I think bleeding is so important as a barrier to appropriate anticoagulation, how I predict bleeding, and finally, strategies that I may use to prevent bleeding or minimize the burden of bleeding, and thereby ultimately to anticoagulate more patients with atrial fibrillation. So why is bleeding important? I've already suggested to you it's common. When we look at trials of anticoagulants in atrial fibrillation, the stroke rates are 1, 2, 3%. The bleed rates are 2, 3, 4% for major bleeding. And then when we add minor bleeding or less serious bleeding, we're looking at 5 to 10% per year. So it's common. It's associated with bad outcomes. If you look at a bleed and you follow such patients over time and forget everything else, forget what treatment you did or did not give for the bleed, that bleed is a marker of bad outcome. Now, it may be that the bleed occurs in a patient who's destined for a bad outcome. It may be that the bleed occurs in a patient who then stops antithrombotic therapy. It may be that the bleed is treated with certain therapies that lead to bad outcomes. But come what may, the bleed is a marker of bad outcome. And it's desirable to reduce the incidence of such bleeds. Most importantly, those bleeds and awareness of those bleeds is a barrier to you and me using anticoagulants. Although the best evidence suggests that those at highest risk of bleeding are at highest risk of stroke and therefore will benefit from an anticoagulant, we decline to treat patients that we are concerned about in relation to bleeding. So that's why bleeding is important. And the importance of bleeding has a rational basis. When we look at, for example, warfarin use in Ontario, and here are some data that I've shown many times, but from 2013, the CMAJ, 125,000 Ontarians started on warfarin for atrial fibrillation. Here is their bleed risk on the y-axis, and time is on the x-axis in 30-day windows. And we've divided the patients here according to their CHAD score. I focus your attention on the black line. If we start a patient on warfarin, this is the first 30 days. The annualized, or the proportion of patients per person year that presents to the emergency room in the first month, it's actually 10%. If we follow patients out for 5 years, every year, 3 to 4% of patients on warfarin will present to the emergency room with bleeding. So a good basis for fearing bleeding, particularly with warfarin. Fear of bleeding as a barrier to anticoagulation. Lots of data on this topic. The one I like to show is from Elaine Heileck in Boston. She divided 200 people not prescribed warfarin by their physician according to their age, less than 80 on the left and over 80 on the right. And then she further subdivided the physician-cited reasons for not prescribing warfarin into concerns about bleeding in the blue, concerns about falls in the orange. And if we just restrict it to those two categories alone, we're over half of patients under the age of 80, and we're getting close to 2/3 of patients over the age of 80. Concern about bleeding as a barrier to anticoagulant therapy. Now, the last piece about bleeding, before I move on to strategies to try and reduce the burden of bleeding, is to look at the disconnect between our patients and their fear of stroke versus bleeding, and we as physicians, our fear of stroke versus bleeding. This is a very elegant study. It's just very simple. 120 patients, 120 persons, half of them are patients, half of them are physicians. And a simple question, how many bleeds would you be prepared to take to prevent one stroke? In the white is the patients, in the orange is the physicians, the number of bleeds that we'd be willing to accept to prevent one stroke. For physicians, we're right across the board. Some of us say it's about 1 to 1, not very many, I think that's probably one person. Some of us are prepared to go as high as, I'll take 20 bleeds to stop one stroke. But look at our patients. The patients don't agree with us. While there is a spread, more than half of patients say, I'll take more than 20 bleeds to protect myself against one stroke because I absolutely do not want to have a stroke. Just something to think about as we sit in front of our next patient at the clinic on Monday morning and we consider a decision about anticoagulation and our concerns about bleeding. Think about what our patients actually perceive, what they might want. I've given you a snapshot on why I think bleeding is important. It's common, it predicts bad outcomes, it's a barrier to appropriate anticoagulation. How do I predict bleeding? How do I face this issue of bleeding? Now, our guidelines will tell us that we have bleeding risk scores. And some of our guidelines actually tell us that we should use them. Here are some of the risk scores. Has bled, hemorrhages, atria, orbit, ABC bleeding risk score. And at this stage, I often ask an audience, how many people use one of these? And the courageous, those few amongst us who actually use a score, put their hand up, and it's usually about 4 people out of 200. And then I tell them, why on earth do you use this bleeding risk score? Because personally, I think it contributes as a barrier to appropriate anticoagulation. Because we get a score, and what do we do with that? The only thing we can do with that is stop ourselves from anticoagulating people. Now, I'm part of the problem. This ABC bleeding risk score, something we published, and I was a co-author, and it came out in The Lancet recently. And it's terrific because The Lancet looks good on your CV, you've got a good paper. Frankly, a completely useless yet another bleeding risk score, which no one can apply and which I hope you never ever use. Because the problem is, if you apply a CHAD score for stroke, a whole lot more useful, I think, than a bleeding score. If you apply a CHAD score, you can predict bleeding pretty well. In fact, we've just submitted a paper where we make the claim that a CHAD's VAS score is as good as a has bled score for predicting bleeding. In fact, they're both pretty lousy. They're not very predictive. They're the best we have, but they're not very good. So my message to you about bleeding risk scores is, if you want to use them, I'm not sure why, but if you do, I wouldn't stop you, but I'd rather focus you on modifiable bleeding risk factors. Because I think the scores have little clinical utility and they're a barrier to appropriate anticoagulation. Instead, what I suggest to you is, what are the things in patients that make us worry about bleeding? They're old, we can't modify it. They got bad kidneys, not much we can do about that. They got lots of comorbidities, so be it, we'll treat them, but we can't eliminate them. But there are some modifiable bleeding risk factors that we can do something about. On the left side of my slide, poorly controlled blood pressure, get it under control. They're on aspirin or a non-steroidal, get the aspirin off if you're going to anticoagulate. In almost all situations, the non-steroidal, sometimes you just got to keep it going because it improves the quality of life. Lousy INR control, get them off the warfarin if you can, and previous GI bleeding, put them on a proton pump inhibitor. And then anticoagulate the patient. In almost all cases, anticoagulate the patient. The people who you're not going to anticoagulate, if they're actively bleeding, they just had an intracranial hemorrhage, you're not going to anticoagulate them. That's pretty obvious. You don't need a bleeding score for that. Think about modifiable bleeding risk factors, tackle them, and then put them on anticoagulants. The higher the risk of bleeding, in almost all cases, the higher the risk of stroke. That's it for me for predicting bleeding. I think intuitively we're pretty good at knowing who's at higher risk of bleeding. I think what we've got to get to is recognize that those at higher risk of bleeding are also at higher risk of stroke and will benefit from anticoagulant therapy. I didn't show you those data in the interest of time, but that's what the evidence indicates. The last part of my talk, strategies that I use to minimize the burden of bleeding. Now, in part, those strategies include addressing modifiable risk factors. Before I come to that, I'm going to come back onto patient selection. And there's an overlap here between predicting bleeding and preventing bleeding. But patient selection, I just made the case to you that those at highest risk of stroke are at highest risk of bleeding. And I do have one slide on this, just to dispel the notion that by not treating high-risk bleeding patients, we're doing them a service. Now, on this slide, it's a complicated slide, but on the x-axis is risk of stroke. On the y-axis is risk of bleeding, as determined by one of the bleeding risk scores, has bled. 180,000 people, either on an anticoagulant or not on an anticoagulant. Those at highest risk of bleeding, a very clear benefit of anticoagulation. Those at lowest risk of bleeding, a clear benefit. Those at highest risk of stroke, a clear benefit. Those of lower risk of stroke, a clear benefit. Observational data, but just emphasizing that having a high has-bled score doesn't mean the patient won't benefit from anticoagulation. On the contrary, they're likely to have an even greater benefit because they're at highest risk of stroke. More importantly, to reduce the risk of bleeding, I'm going to tackle modifiable risk factors, and I'm going to choose the safest anticoagulant. Now, I'm going to be a lot stronger than the former speaker, Dr. Verma, with respect, because I think it's an absolute no-brainer. NOACS are the way to go. The relative reductions in bleeding are modest, but in absolute terms, on a population basis, they're enormous. Now, consider for a moment, and I'll just take the top treatment here. This is dabigatran 150. Imagine for a moment that dabigatran 150 was the standard of care today, and we did a trial against a new drug, this wonderful new drug called warfarin. Forget for a moment that for the rest of your life you have to go to a lab every 4 weeks, restrict your dietary intake and your alcohol intake, watch out when you travel. Forget that just for a moment. But imagine you've got this new drug called warfarin. You do a trial, and the trial shows that the new drug has an almost 20% higher rate of stroke in relative terms, almost 1 in 5 higher rate of stroke. It increases the risk of bleeding. Not just bleeding, it doubles the risk of intracranial bleeding, and it has a 15% higher cardiovascular mortality. There's no way that drug would ever be approved for clinical use. And you can do that set of sums with any of these agents and indicate that today, if warfarin was tested against any NOAC, it would never be approved. It would be deemed unethical to approve it. Now, I'm delighted we've got warfarin because it gives us unique opportunities to treat some patients. But in the last 5 years, I've never knowingly started a patient on warfarin. I think it verges on the, let me not say it, but you've got to use the safest treatment for your patient. And these clearly are at least as effective, and they're a lot safer. And they will become the dominant treatment in Canada. They already take about 50% of prescriptions first up, and they are the safest way to reduce bleeding. Now, is that true in the real world? We've got 75,000 people in the trials. This is just a little meta-analysis of real-world data. Observational data, a mere 500,000 patients, because it's restricted only to the highest quality studies. 500,000 people. The estimates from the trials are on the right. The estimates from the real world are on the left. And the first thing you notice is that all the estimates from the trials and from the real world for every outcome that is relevant for our patient is in favor of the NOAC. These are modest relative risk reductions, both for the trials and for the real world. But again, they're always in favor of the NOAC, and they're completely consistent in the real world and the randomized trials. We have never had such an overwhelming array of data within such a short time on a new therapeutic intervention that demonstrates consistently a favorable effect of the new treatment in trials and the real world. Now, what about if we have a bleed in a patient on a NOAC versus a bleed in a patient on warfarin? Here are the data on case fatality, dead bodies after bleeding. A NOAC and warfarin. In every case, there are less dead bodies when you bleed on a NOAC versus warfarin. There is no exception. Very crude, nothing fancy about this analysis, but it's in favor of the new treatment. in the absence of a reversal agent. So to prevent bleeding, I'm not supporting patient selection, but I'm thinking about sensible risk factor modification. And I'm saying choose the safest drug. Now, what about treating bleeding? Is there something we can do to reduce the burden of bleeding by more effectively treating? You've seen this sort of slide in the past. Every guideline comes out with a great big algorithm on how to manage bleeding. I suspect that many of you are in primary care, and thankfully for you, most of you don't have to deal with the serious bleeds. And thus, slides like this make pretty colors. They give you a warm glow that someone out there knows they've got access to an algorithm to treat bleeding, but it doesn't really matter to you. But I hope that by showing you this algorithm, you can also get confidence to use anticoagulants more widely to treat more Canadians with atrial fibrillation at risk for stroke. Now, it's been said earlier in this meeting that the antidotes may not be that important. I was a complete subscriber to that view until the last 2 years, when I personally have treated more than 20 people with an antidote. It's a rare occurrence, but it is a tremendously important occurrence. In the case of bleeding, yes, it does still take time for the bleeding to stop. I'll show you a little bit more data on that. But in the case of urgent surgery, it revolutionizes the management of the patient. It's night and day. Speak to your surgeon, your anesthesiologist, your emergency room physicians. In the rare case where you need to go rapidly to the operating room, it makes a huge difference. Now, when might we want to reverse anticoagulation? There are basically two key categories: people who need procedures and people who have bleeding. But there are some additional categories. For example, the patient presenting with acute stroke. And in such cases, if they're taking a NOAC, we may wish to eliminate the drug to give thrombolysis. Is there any evidence that rapid reversal is beneficial? In the case of warfarin, we have no clinical outcome studies, but this is a provocative paper published earlier this year comparing fresh frozen plasma with PCC for reversal of warfarin in patients with intracranial hemorrhage. And a very important result from this study. For the first time, it was shown that rapid reversal of warfarin with the PCC reduced hematoma expansion. Now, we've probably got some stroke docs here, but the jobbing stroke doc who deals with this for a living will immediately say, or certainly the neurosurgeon who deals with this for a living, will immediately say, that's a highly desirable outcome, because we want to stop hematoma expansion because we know that leads to bad outcomes. Now, PCCs do work very well with warfarin, but they do cause thromboembolism, and certainly when you reverse with a PCC, you do get more thromboembolic events. And that's been shown pretty much uniformly. So while PCCs may promote thrombus formation, may promote hemostasis in the NOAC-treated patients, there is a potential for thromboembolic complications. Where the field is moving to is the introduction of specific reversal agents. And there are 3 such agents that are in phase 2 trials or above, or more later trials. One of them is called Praxbind, or idarucizumab. The second is called andexanet alpha. And the third I won't talk about because it's too early in its stage of development to be of any relevance to most of you. Now, Praxbind is a humanized antibody fragment. It's like DigBind that those of you who work in an emergency room may be familiar with. It binds to dabigatran and instantaneously, completely, and permanently reverses its anticoagulant activity. Comes in a little clear vial with a little bit of fluid in the base of the vial. It can be given in 2 or 3 minutes. It's given as a push or a rapid infusion, and it works instantaneously in pretty much all patients. We've just presented data on the first 494 patients treated with this. That is the second report. The first report was on 90 patients. The second report was 494 patients. I'll show you the data. The second reversal agent, andexanet alpha, is being developed for the 10A inhibitors. Unlike this antibody, it binds to 10A inhibitors in a competitive manner. It's got a short half-life, so when levels are high, you reverse. As they wear off, your anticoagulant activity comes back. The Annexa-4 study we've just published in the New England Journal of Medicine a couple of months ago. Patients were enrolled if they had bleeding. Having signed the consent, they receive an intravenous bolus followed by an infusion of andexanet alpha, and then we measure reversal as well as clinical events. Here is the reversal for rivaroxaban. Now, the number of patients is small. In total, 67. There's just over about 25 patients with rivaroxaban and a similar with apixaban. On the left-hand side here, we have the drug levels before reversal, and then over time, we have drug levels. We see reasonable reversal, but still a substantial proportion of patients who are not reversed at the end of the bolus. We can continue the infusion to 4 hours, to 2 hours, and this is the level at the end of the infusion. And then we stop the infusion and anticoagulant activity recovers. So it certainly reverses, but not permanently and not completely. The good news is that most of these people had reasonable hemostasis in terms of the bleeding being reduced or stopping. Now, apixaban reversal. Apixaban's drug levels are here, and the similar data as we go across the page. This is the end of the bolus, the end of the infusion. We stop the infusion, and we get some recovery. This reduction in anticoagulant activity may be enough for people with bleeding because you don't need to have perfect hemostasis. We need to learn a lot more about this agent. We're going to expand this study to include surgical patients, and those data will be required before this treatment is going to be approved. Reverse AD, you may have seen some of these data before, but this is the update on the 494 patients. Unlike Annexa-4, we included both surgical and bleeding patients. They got the stuff as a single bolus injection and then were followed for 90 days with blood tests and with clinical outcomes. Now here are the data, not on a blood test, but here actual measured drug levels. The left-hand side, the dabigatran drug levels before the antidote. Here they get the bolus injection. It's actually 2 vials that are squirted in, and we took a blood test in between. And here are drug levels after administration. And you can see it's basically a horizontal line. All of the drug is instantaneously removed from the system. Now imagine you're a surgeon or an anesthetist and you want to do an urgent drainage of a subdural. You want to do a craniectomy, urgent cardiac surgery, a ruptured aorta, bleeding from your urinary tract. You want to do an epidural or a spinal. When you see these data, you can be very reassured and confidently go ahead with that sort of procedure. On the left, we have the bleeding patients. On the right, we have the surgical patients. And in all cases, there is complete reversal, which is sustained for at least 4 hours, and in most people for 12 hours. There is some recovery here, and I can explain that, if you like, at the time of the discussion. Now, what about bleeding and thromboembolism? In the Annexa-4 study, in the first 67 patients, there was an 18% rate of thrombosis. We're not sure quite what that means. In the reverse AD study, there was an overall 4.4% rate at 30 days and 6.3 at 90 days. Not bad for a population that's almost 80 years old, that's critically unwell, that's hospitalized, for whom we remove anticoagulants. Now, what about cessation of bleeding? In the first report, it was said to be 11 hours. But that 11 hours included intracranial hemorrhages where it was impossible to know when bleeding stopped. A more refined analysis on a much larger population suggested somewhere around 3 to 4 hours for cessation of bleeding, and more than 90% of people who had surgery had normal hemostasis. The other really important part of this reversal is it gives physicians confidence to treat the patient rapidly and then to get them back on anticoagulants. No less than 90% of the surgical group got back on an antithrombotic, and the median time to restart after reversal was just 1.2 days, a little longer in the bleeding patients. So, Mr. Chairman, ladies and gentlemen, I've discussed with you the issue of bleeding. And ultimately, the most important message is we've got to treat more Canadians with effective doses of anticoagulant therapy because we still have a substantial burden of unprevented stroke. The biggest barrier is our fear of bleeding. The data suggest that we are in the safest possible zone ever in respect of anticoagulation. The best way to reduce the burden of bleeding is prevention. The best way to prevent is to address modifiable risk factors and use the safest anticoagulant. I think the reversal agents are tremendously important. They'll only be used in less than 1% of your patients each year, but when they are required, they do work dramatically well, and I hope that they will further improve your confidence to treat more Canadians effectively with anticoagulants. Thanks very much for your attention. And a terrific guideline on Thrombosis Canada website.
Our next speaker is Dr. Andrew Ha, who's an electrophysiologist, has extensive experience in research using administrative databases and specific expertise in sort of understanding the truth behind so-called real-world data. Andrew's going to talk to us about what we've learned from administrative databases and registries. Andrew, thank you.
Thanks for the invite. I'm honored to speak at this talk here. So I was asked to talk a little bit about some of the lessons that we have learned from real-world registries and also administrative databases, basically observational data with respect to oral anticoagulation in the context of AF-related stroke prevention. I'll be discussing some off-label use of approved products in this talk. So before I start, I just want to, you hear about these terms interchangeably. In this talk, we're going to use NOACS. Either stands for novel or new oral anticoagulants or non-vitamin K. Also, you hear often it's referred to as DOAC. Both terms are interchangeable and used often, so they're kind of the same for me. So there are three main objectives in this talk. First, I want to review some of the strengths and limitations of observational research in the context of OAC, oral anticoagulation, for AF-related stroke prevention. Second is to discuss some of the key messages that we have learned or derived from contemporary studies on AF and OAC based on registries and admin databases. And third, I want to talk a little bit about the real-world data on OAC use for AF stroke prevention, specifically in the context of warfarin versus NOAC, and also NOAC versus NOAC studies, because they're here, they're published, you'll be inundated with it, and I think it's good to have a sense of the nuances of these studies. So I think I just want to take a step back and just reiterate that randomized controlled trials remain the gold standard for assessing the efficacy among interventions. What we mean by efficacy is how well does the intervention work under ideal situations, drug A versus drug B, for instance. Whereas effectiveness is how well does the intervention work in the practice of medicine, like in routine clinical settings. So efficacy is best assessed with RCTs, whereas effectiveness is better assessed with observational data, real-world registries, etc. Just remember, randomized controlled trials also are real-world data too. So what is a registry and why is it useful? A definition of registry is that it's an organized system which uses observational study methods to collect uniform data to evaluate specific outcomes related to a particular disease, and it serves either a scientific purpose, a clinical purpose, or even a policy purpose. They're particularly useful in describing the real-world experience of how doctors assess and manage a disease. They are very useful in describing the trends of the disease, rates of OAC use, etc. And also, they're quite important and useful in examining the impact of physician practice on the quality of care, prescribing preferences, and other outcomes which may not be easily quantified or addressed by RCTs. So it's important to realize that this is kind of the main strength of registry observational type data. Traditionally, a registry involves enrollment of patients on an individual basis. You see a patient, they fit the criteria, you can send them into the study and follow them prospectively. However, in the past five years or so, a lot of information can be derived from cohorts from admin databases like big data, like hospital discharge databases, drug claims, and billing databases. In this study, we will review studies using either or both methods. I think some of the pros and cons or strengths and limitations of both types of designs are as follows. With enrollment-based registries, sometimes it may be prone to selection bias because you may be picking and choosing the patients into the registry, whereas if admin databases, may be subject to less bias if you're collecting hundreds and thousands of patients in a population-based level. Enrollment-based registries tends to be prospective, so you identify and follow them prospectively, whereas if admin databases, you're looking things retrospectively with some methodological limitations. In both types of design, the sample size can be large, but with admin databases can be very large. You can be talking about hundreds of thousands of patients or even millions. The level of detail can be higher in enrollment-based registries because you have more granular detail, whereas it's generally less granular in admin databases. Outcomes in registries tend to be pre-specified and may be adjudicated under strict definitions, whereas admin databases is not adjudicated and tends to be relied upon the discharge coding summary. Cost, enrollment-based registry can be quite expensive if you're enrolling thousands and thousands of patients, whereas if admin databases, the cost of doing the study is lower. Also, from study conception to publication tends to be longer in enrollment-based registries, whereas if admin databases tends to be faster because you don't have to consent patients and follow them prospectively. I think I'm going to, during this talk, talk about some of the messages which I think are important when we try to look at these studies and some of the things which I gleaned from these studies. The first aspect I want to talk about is the real-world data on the effectiveness and safety of warfarin versus NOACS agents. I just want to go, once again, step back a little bit and talk about some of the RCTs. So there are 4 pivotal trials comparing NOACS agents to warfarin, dabigatran, rivaroxaban, apixaban, and indoxaban. And when you pool the data of these trials, this is a slide pooling 3 RCTs, RELY, which is looking at dabigatran, Rocket AF looking at rivaroxaban, and Aristotle looking at apixaban. When you pool them together, this is kind of the gold standard. It suggests that NOACS agents as a whole is better than warfarin with respect to reducing the chance of stroke or systemic embolism, reducing the chance of any stroke, and reducing the chance of hemorrhagic stroke, intracranial hemorrhages. So this is the reference point which we should keep in mind when we interpret the administrative data, which I'm going to do so in the next few slides. So I just for the slides, I'm happy to share them. I think all you have to do is ask Kyle for a copy, and you'll be able to have access to the copy of these slides for your own references. So let's jump into some real-world data. So I think there are many. In the past year, you can identify 10 to 15 published studies looking at real-world data using admin or registries. This is one of the best ones, I think. It's one published recently in a British Medical Journal. It's an observational nationwide cohort study comparing the effectiveness and safety of first-time users, so treatment-naive people, on various OAC agents, warfarin, apixaban, rivaroxaban, and dabigatran. The strength of this study is that it is large. It includes about 62,000 patients in Denmark, so it's population-based, and it's fairly contemporary from 2011 to 2015. They look at a number of outcomes: ischemic stroke, systemic embolism, death, major bleeding, and intracranial hemorrhage. And when they compare the agents to warfarin, these are the findings. I think the key finding of this whole slide is that the results are generally consistent with what you observe in RCTs. For instance, when you compare apixaban to warfarin, it's superior to warfarin with respect to death and major bleeding. Interestingly, no difference or not worse, but compared to warfarin, similar. In rivaroxaban, there seems to be a slight improvement compared to warfarin with respect to reducing ischemic stroke or systemic embolism. And once again, most of these boxes are either to the left, which favors the NOAC agents, or crosses the midline, which means that they're equal. So that's kind of the context of this study. I think one of the messages when you look at other studies, of which there are many, the message is fairly consistent. They appear to confirm the results of randomized controlled trials comparing NOAC agents to warfarin. Just want to talk about, then move on to another concept, the real-world effectiveness of these agents in of itself, like not comparing to anything else in of itself. I think this is a very good study called the Xanthus study, led by Dr. Turpie. I think he's in our audience here. This is an observational prospective study of patients treated with rivaroxaban for atrial fibrillation stroke prevention. The design is an observational single-arm cohort study, so it's an enrollment-based registry. So you need to consent them and get them into the study. And they follow a number of key events: adverse bleeding events, stroke, systemic embolism, mortality, amongst patients with non-valvular AFib treated with rivaroxaban. It's a large registry composing of about almost 7,000 patients from 300 centers across Europe, Israel, and Canada. And these are patients who got started on rivaroxaban to prevent stroke in the context of AF. And these patients are followed quarterly and with final visit at 1 year, and with all the outcomes being adjudicated with strict criteria. I think some of the key baseline demographics are that this is the rivaroxaban arm of ROCKET-AF, the randomized trial comparing the NOAC to warfarin. I think the things I'm seeing is that in Xanthus reflects the patients who are enrolled in routine clinical practice. They tend to have lower CHAD score compared to the ROCKET-AF trial, also lower rates of heart failure, stroke, systemic embolism, renal disease. So there is some difference with respect to the population enrolled in the randomized trial versus what was enrolled in this kind of real-world routine practice registry. And I think the outcomes kind of reflect that. One way to see it is that the outcomes of this prospective study is fairly similar to the randomized trial, perhaps even lower. But with the understanding that the population who is enrolled in this routine care registries are a little bit less sick compared to the ROCKET-AF. But generally speaking, the rates of stroke, systemic embolism, major bleeding is about less than 2% per year, with only a 1-year follow-up, though, in this kind of registry. These outcomes are adjudicated with strict criteria, and unlike admin databases, which uses coding discharge diagnosis to get the results. I think I want to then switch gears a little bit and talk a little bit, go a bit further into what we want to know. Recently, there have been a few studies comparing the head-to-head effectiveness of NOAC agents. And I think I just want to reiterate that randomized trials are still the gold standard when comparing the efficacy amongst interventions like drug A versus drug B. So the results derived from these studies should be interpreted with this concept in mind. I want to talk about a few studies here. So this is a very good study, recently published in JAMA Internal Medicine. It's an FDA-commissioned analysis of almost 120,000 patients who are first-time users of rivaroxaban or dabigatran. And what they looked at is their outcomes with respect to stroke, intracranial bleeding, major GI bleeding, and death. In the outcome of thromboembolic stroke, the rivaroxaban and dabigatran are similar. Probably a bit of a trend favoring rivaroxaban compared to dabigatran. On the other hand, rates of intracranial bleeding and major bleeding are a little bit higher when you look at rivaroxaban versus dabigatran, whereas the rates of death are similar. There's a trend towards a little favoring dabigatran, but just did not meet statistical significance. So this is a large retrospective analysis, FDA commissioned, of older Medicare patients in a fairly contemporary era. I think when you look at this data, you want to ask yourself, how do you interpret? Does it mean this is better than that? I think when you interpret it, always keep in mind that, this is probably more along the line of hypothesis generating, and that you really need an RCT to really tease out and confirm and validate these findings. I think when they also did a nice job quantifying the difference between these two drugs. When you look at the adjusted rate incidence per 1,000 person years of the two drugs, of these 4 outcomes, some of them are statistically significant, such as intracranial bleed or major bleed. But I think, on a per patient basis is still fairly minute in terms of the difference from drug A to drug B, rivaroxaban versus the bigatran. And I think that needs to be kind of kept in mind when you see a patient and deciding which drug is better on an effectiveness basis. Perhaps on a populational base level, there may be some major implications, but that needs to be validated with RCTs with respect to the findings. But on a per patient level, the difference is not that big when you compare, when you're talk about a 2 out of 1,000 difference, which means that 998 of the times it's similar. The next study, before I talk about it, I want to talk about this database. It's called a Truth and Market Scan database. It's a US claim insurance claims database consisting of a family of databases which records a wide number of claims. Includes hundreds of millions of patients, very large size, and provides longitudinal data. Potential limitations is that it only includes some of the larger carriers, so the smaller carriers are not included. Only includes US patients with private insurance plans. And there may be some issues of coding errors, which is the same for all admin databases. Dr. Lip recently did an analysis comparing the real-world outcomes of major bleeding amongst patients who are first-time users with warfarin, rivaroxaban, dabigatran, or apixaban. So he used this databases and patients who are insured through this, who are insured and whose data is in the database in a span of 2013. And they looked at what is the rate of major bleeding defined as bleeding requiring inpatient hospitalization with this database. And he wanted to do some comparison amongst these 4 agents. When you look at the baseline demographics, a fairly significant number of patients were included. 2,400 with apixaban, 4,173 dabigatran, over 10,000 patients on rivaroxaban and warfarin respectively. The baseline demographics, I think, amongst the 3 NOACS agents are fairly similar, whereas for the warfarin group, they tend to be older, sicker, and have more comorbidities, reflecting perhaps what we see in our own clinical practice. This is a slide that's presented in various publications you might come across or shown by various peoples. I think the finding of this analysis suggests that there may be some difference with respect to the different NOACS agents in terms of the rates of major bleeding defined as bleeding requiring inpatient hospitalization. And so this is one of the head-to-head comparisons you're going to see, and it's going to come out more and more in the next few years. But like I said, ideally, these findings should really be confirmed and validated with an RCT. With respect to the effectiveness and safety of NOACS agents, registries, well-done registries such as Xanthus suggest that they're safe and effective. I'm happy about that kind of result. With respect to head-to-head comparison of the effectiveness and safety of NOACS, these data suggest there may be some differences between NOACS versus NOACS. But like I said, it should be confirmed and validated with RCTs. One of the questions you come across is, does it mean that warfarin is obsolete? I'm going to show one slide. This is, once again, a very nice study, recent from Sweden, 40,000 patients from a registry, 2006 to 2011, with a pretty high CHA2DS2-VASc of about 3. Stable INR is defined as patients with a spread of INR between plus minus 0.8 from the mean value. And the major finding is that patients with a time in therapeutic range of more than 70%, denoted by these two groups. So this is the stable, more than 70%, unstable INR, more than 70%, have lower rates of thromboembolism and major bleeding compared to those patients with a TTR less than 70%. In fact, when you look at the annualized rates of these patients with a TTR more than 70%, they're quite low. Major bleeding, 1.6% per year, arterial thromboembolism, 1.4% per year, and intracranial bleed, 0.34% per year. One of the messages that you can glean from this is that if a patient is on warfarin but has good INR, which in this study defined as a TTR more than 70, in the real world, they don't have high rates of bleeding and stroke. And, a case can be made that you don't necessarily have to switch them over to a NOACS agent unless there's some other compelling indications. So I think the message based on studies like these suggests that if you have a patient with a good time in therapeutic range defined as more than 70%, they have pretty low rates of thromboembolism and bleeding, less than 2% respectively. The final phase of this talk, I want to focus on a little bit of the quality of care, care gaps, etc., with respect to AF OAC management as gleaned from administrative databases and registries. I think one of the key questions clinicians want to ask is, do AF patients who are at risk for stroke, are they receiving appropriate antithrombotic therapy? This is from the Garfield Registry, another enrollment-based registry, international study looking this phase of Garfield, of which the total phase will enroll about 50,000 patients, included 17,000 patients of new onset AF from 30 countries between 2010 and 13. The finding is that there are a few findings. I think one of the things we notice is that, let's say CHA2DS2-VASc 2 or greater, the rates of OAC use, which is the combination of the blue and the red, VKA and NOACS, is up to about 50 to 60%. Glass empty, glass half full. Not great, 50 to 60% of at-risk patients. On the other hand, patients with low stroke risk are still, a substantial number of them are still on an oral anticoagulant in spite of a CHA2DS2-VASc of 0, let's say. So that's concerning to a degree. And I think it gives us some insight that many patients who are perhaps potentially eligible for stroke prevention may not be getting it. I want to point out that Canada contributes some patients, but not a lot, about 1.6% in this registry study. This is from the United States, from the Pinnacle Registry. So it's a practice audit quality improvement kind of study. They enrolled almost 200,000 patients with atrial fibrillation from 123 practices in 38 states between 2008 and 2012 with elevated CHAD score, more than 2, who were treated with an antithrombotic agent. The key finding is that 62% of these patients were treated with an oral anticoagulant. And I think this is a graph showing the rates of OAC use by practice. As you can see, there's a wide spread. Probably about 20% of them had a 70% or better rates in terms of prescribing OAC, but some of them are quite low. So I think what's the message from this slide is that, in the United States, 62% treated with OAC, although they're at risk, and there is huge practice variation when you look at even the 123 practices. They also look at some of the factors which may be associated with OAC use versus non-use. One of the findings which they observe is that if there's a history of atherosclerotic disease, PAD, peripheral vascular disease, angina, or CABG, you are less likely to receive oral anticoagulation and more likely to receive aspirin. Whereas if you have the more traditional factors of CHADs, heart failure, diabetes, previous stroke, you're more likely to receive OAC. So one of the interesting findings gleaned from this type of practice-based registry. In Canada, this is a prospective, a Sprint AF registry is a prospective Canadian study enrolling about 2,500 patients from 130 sites, pretty contemporary, just finished enrollments. This is an abstract presented at the CCS. The rates of OAC use are higher in this registry. For instance, anyone with a CHA2DS2-VASc of 2 or greater have a 70 to 80% use of OAC use in this registry. I think, obviously there's differences in design and potential selection bias when you look at smaller registries versus very big registries. But I think the other thing is, it may reflect that there is a lot of non-clinical determinants of OAC use, socio, geopolitical factors, cultural. So I think when you look at real-world studies, you prefer to look at studies derived from your own neck of the woods, perhaps, I would say. Use the global stuff, as a reference, but always try to get some local data to see if it's congruent with your practice pattern. Another thing that's very useful with these studies is they can look at adherence. So this is from the United States, insurance claims databases. So they look at adherence over a period of 1 year. Adherence is defined as having a proportion days covered of more than 80%, because every claim, every drug claim is processed by the insurer. So there's a way to figure out how many pills the patient filled over a period and calculate the percentage of number of pills which are paid for by the insurer. What this suggests is that over a year, the adherence rate uniformly across the board is not that great, but appears to be a little bit higher with NOAC agents, in the 47 to 52% range versus warfarin. And not surprisingly, it tends to be a little bit higher as your stroke rate is a bit higher. So interesting results, and I think it speaks of potential care gaps, ways to hopefully mitigate these kinds of issues and perhaps force us to find harder for the reasons why adherence may not be as high as we hoped. Another thing I want to point out is that sometimes we can use these studies to look at things which cannot be addressed by RCTs. This is a study from the United States from a large dialysis database. There are patients, they notice, who were treated with NOAC agents in spite of being on hemodialysis. As you know, according to Canadian dosing recommendations, when you have creatinine clearance less than 25/30, these agents are considered to be contraindicated. What they notice is that in spite of this, there is still not a non-trivial percentage of hemodialysis patients with AF who are treated with a NOAC agents. And you see that since approval by FDA, there is a uptake of these drugs in the dialysis population, even though it's not, it's off-label and it's basically contraindicated. And what they observe is that these patients have higher rates of hospitalization or death compared to those treated with warfarin. So once again, something that cannot be addressed by RCT, something that we normally typically wouldn't use, but this is an example of showing us what would happen, in this kind of off-label setting. So, RCTs remain the gold standard for addressing the efficacy amongst interventions, but on the other hand, observational data is very useful to provide us with complementary data on the real-world contemporary use of these drugs, practice patterns, heterogeneity in stroke prevention, bleeding risks in the real world. Observational data can be derived from enrollment-based registries or administrative databases. Strengths and limitations, however, exist in both sources. These data suggest that NOAC agents reduce adverse outcomes like stroke, intracranial bleed compared to warfarin and are consistent with RCTs. There's some differences, it seems, that they're between NOAC versus NOAC, but they should be addressed with formally with an RCT. And I think that these are quite important to inform us how things are done in real world, and hopefully we can identify ways to hopefully improve on some of our perceived limitations in our practice based on these studies. Thanks for your attention.
Thank you very much. Andrew had some very provocative data that we'll have a chance to discuss in the discussion period. We're now very fortunate to have Dr. Talajic, who's a professor of medicine at the Université de Montréal. He's chair of the Department of Medicine, has an extensive record of investigation and outstanding teaching, and he has the enviable task of telling us what is the most efficient way of using the direct-acting agents. Notice effectiveness, as Andrew defined it, is in clinical trials, but in the real world, we're looking for efficiency, practical concepts, and Dr. Talajic will give us the kind of practical bottom line. If you're going to make chocolate cake, exactly how do you do it so it tastes good?
So these are my disclosures, and in fact, what I decided to do was actually change I put it sort of in the context of what I kind of understood by the topic. And so I think the reality is that when you take care of patients who have atrial fibrillation and you're using NOACs, it's not a simple matter, AF, NOAC, next. Unfortunately, each of these patients fall into very specific, we all have individual patients that have very specific circumstances that you have to deal with. And so when you do use NOACs or any anticoagulant in the context of atrial fibrillation, you have to be able to evaluate in the context of a management of a more complex disease and more comprehensive care of the patient. So on this slide, I've just listed a bunch of things to think about that we have to think about during our day-to-day practice. I will not address all of these topics, but in fact, some of them have already been addressed by our speakers up until now, and in fact, some of them will be addressed in future talks as the day rolls along. So I will, however, talk about some of these individual areas. So let's start by just very rapidly say, well, why are we here? Well, it's really it's a very, very large randomized clinical trials, which show globally that NOACS reduce the incidence of stroke approximately 20% as compared to warfarin. And if you say, okay, well, how does this actually work? When you get a 20% reduction in stroke, the greatest proportion of this effect is because it reduces hemorrhagic stroke. So the effect on the ischemic stroke, non-hemorrhagic stroke, is actually much more modest, and in fact there's only one of the molecules that actually has a significant effect, and that's the high dose of dabigatran. But in fact, the great majority of the effect in terms of efficacy is because there's a dramatic reduction in intracerebral bleeding. So these, in fact, could be interpreted as these are safer. They're safer in terms of the blood-brain barrier. Looking at the bleeding side globally, this has been addressed already into some detail, but overall a 14% reduction of the NOACS compared to warfarin in terms of bleeding. So having said that, now I sit on the guideline committee along with Paul, and it has been mentioned that the Canadian Cardiovascular Society guidelines say that a NOAC is preferred over warfarin, and basically the reasons are shown here. It's because of the convenience and ease of use for patients and physicians. And the second statement, which I think is true, that all NOACs are at least as effective, and at least as safe as warfarin. Some of them have greater efficacy for stroke and mortality, and some actually have greater safety, depending on the clinical trial and the drug and the dose that was chosen. We've already had some extensive discussion this morning about where do you give warfarin, and it was mentioned that mechanical prosthetics valves, that's an absolute, that's been evaluated in a randomized clinical trial, and warfarin was the big winner, the NOAC was the big loser, so that's clear. Rheumatic mitral stenosis is also included on this list, not because intrinsically we know that warfarin is better, it's because we just don't know, it just hasn't been studied. These patients are all excluded from the randomized clinical trials. And then we've alluded to severe renal dysfunction, where these drugs are currently contraindicated. Of these three, I'm not sure that the last one will actually apply as we move forward, and I'll show you some data later this afternoon. Well, at least some of the trials that are ongoing starting to study this question. And in fact, there was also allusion that there is a trial going on rheumatic heart disease, but whether or not this is true, that NOAC is truly contraindicated. But I think the final word has been written for mechanical prosthetic valves. Now, Andrew mentioned, which NOAC, and although, the first thing, as Andrew mentioned, there are no direct comparisons between the NOACs. And so as a result of that, and there are, however, a variety of indirect comparisons, of which we just saw a few. You have to remember that these are indirect comparisons, they're not head-to-head randomized comparisons. So as a result of that, if you look at guidelines, society guidelines, for example, there are no specific guidelines as to pick which NOAC in which situation. So I'm going to make a couple of suggestions, and these are basically suggestions. They're not based on hard head-to-head comparisons, but you're in your clinic, you see a patient, you've got to decide, well, which patient, and I do think that there are some issues that you should think about. First of all, in somebody who has moderate renal insufficiency, remember that dabigatran, 85% of dabigatran is eliminated by the kidney, whereas rivaroxaban, apixaban, and edoxaban are eliminated 25 to 30% by the kidney. So therefore, and I'm a cardiologist, so I see a lot of patients with heart failure, and one of the things that strikes me is that our so-called patients with moderate renal insufficiency who may have a creatinine clearance of, say, 40, and therefore eligible for all the drugs, what happens is they come in with acute heart failure, and all of a sudden their creatinine is shooting up, their clearance is shooting down, and they could be in trouble. So in general, I tend not to give dabigatran in people who have moderate renal insufficiency, despite the fact that the package insert says that I can. Again, it's a suggestion, it's not a CCS guideline or recommendation. Someone who has a very high stroke risk, now I'm talking about CHAD scores of 5 and 6. Well, the only drug that has been shown to reduce ischemic stroke has been dabigatran at a higher dose, 150 milligrams twice a day. Now, I just mentioned the reason why you might not want to give dabigatran in someone who has renal problems, but this may be a reason why to give it in certain individual patients. Your patient, you're very, very concerned about bleeding. The patient has a lot of risk factors for bleeding. And so, well, if that's the case, there are at least 3 choices, in my mind at least. In the case of dabigatran 110, apixaban, and edoxaban, all 3 in head-to-head comparisons with warfarin showed significantly lower bleeding rates, which is not true for dabigatran 150, which is not true for rivaroxaban. Now, so based on that I think a pragmatic approach to be in a patient who has a very high bleeding risk would be to consider one of these agents versus some of the others. And then finally, there are patients that you're worried about once a day versus twice a day dosing. I personally don't think is a really big deal between once a day and twice a day, but there are occasional patients that will say that they really prefer to take 1 pill only in a day, and if that's the case, your choices are down to 2. It's rivaroxaban or edoxaban. So these are clinical judgments, and I think the other thing that's very important is that as you get comfortable with 1 or 2 of these medications, you tend to use the same ones over and over. At least that's the case in my practice. The other thing I'd like to talk about is the dose. And the title of this slide says Dose Matters. And to try to make this point to you, there were only 2 trials in which the dose was actually randomized. The other trials, there were suggestions on dosing, but it wasn't a randomized choice. It was actually based on renal function and so on. So in the RELY trial, which is evaluated dabigatran, the patients were randomized either to the 110 versus the 150 dose. And what you can see here is that the 150 dose, in fact, had greater efficacy. What I haven't shown you here is the bleeding data, which shows the contrary. It shows that the 110 dose had greater safety than the 150. So dosing here makes a difference. The other trial in which dosing was randomized was the ENGAGE-AF trial, edoxaban. So this drug has just been approved. It will be available very soon in your practices. Again here, this is the efficacy data shown up here. So warfarin is the orange line. The low dose edoxaban, 30 milligrams, is shown above it, so you can see it's actually worse than warfarin. However, the higher dose edoxaban is actually better than warfarin. Now, we can argue about confidence limits and p-values, but the point here is I'm trying to point out to you is that there is a difference depending on the dose that you select. If you look at the bleeding story, warfarin, then high dose edoxaban, then low dose edoxaban in terms of decreasing risk of hemorrhage. So dose does matter. So what are the doses that we have available to us? Well, here they are. The standard dose are shown here. And if we take the case of dabigatran, 150 BID, we have the alternative, at least in Canada, 110 is available, where it's not available in the US. And the decision to use the lower dose versus the higher dose is actually a physician choice. It's your clinical judgment based on the risk of bleeding in an individual patient versus the risk of stroke. And then you decide what you think is most appropriate for that patient. And in fact, 50% of those patients, as I mentioned earlier, in the RELY trial were actually randomized to that low dose. In the case of rivaroxaban, the situation is a little bit different. The standard dose is 20 milligrams a day, and it's true there is a lower dose. Only 20% of the patients actually in that trial actually got that dose. And that was based on dosing based on renal function. In the case of apixaban, which is the one I'd like to concentrate on a little bit, the low dose is actually half the standard dose. There's a dramatic change in the dosing. And here are the criteria that were used in the clinical trial. And in fact, if you look at the product monograph, it's basically copied from the clinical trial. So if you had 2 of 3 criteria, weight less than 60 kilos, age over 80, or a creatinine greater than 133, you got 2 or 3 of those, then you were recommended to receive the lower dose. But how many people in the trial were actually on that lower dose? It was only 5% in the case of Aristotle. Now there are registries across Canada, well not registries, but the pharmaceutical industry does have data, extensive data in fact, on what drugs are being used in Canada and what the doses are. And in fact, unfortunately I don't have a slide to show you, but at least verbally, there are estimates that the lower dose of apixaban, the 2.5 BID is being used in Canada on the order of 30 to 40% of the time. Very, very high proportion of Canadians who get apixaban are on the lower dose. And I see in my own practice, when I do rounds in the hospital, I see a lot of patients on the 2.5 BID dose. And typically, it's not because they've met the 2 of 3 criteria. Often it's because they're frail. They may have one of the criteria and so on. So there's been an arbitrary decision to use the lower dose. And what I'm trying to emphasize here is that I think you should be careful about dosing. In general, you should try to use the standard dose. If you decide to use the lower dose, remember what the criteria are for the use of that lower dose. And to make sure, because I think the one thing that we want to ensure is that that the patients aren't paying a price in terms of inadequate coverage in terms of stroke prophylaxis. Okay. Earlier this morning, we talked a little, there was some mention about drug interactions, and here is just a table which are the most common drug interactions. So it's true that Coumadin has a lot of drug interactions. It's one of the limitations of its use, but NOACS are not completely immune. They certainly have fewer. And what I want to emphasize in this table is basically there are two types of it. One is inducing of liver enzymes, specifically one of the cytochrome P450 enzymes, as well as inducing of P-glycoprotein. The net effect of this is by increasing a liver enzyme and increasing P-glycoprotein, and this is a protein that's found in the intestinal barrier. The more P-glycoprotein that you have, the lower the drug concentration you will have, because it actually affects drug transport across the lumen from the intestine into the blood system. So in the case of a couple of anti-epileptics, carbamazepine, I think phenytoin is on this list as well. And there's also here, I have signed John's wort, which is actually a plant extract that's used often for depression. These three examples, you induce the enzyme in the liver, and you induce the PGP in the intestine, and the net effect of both of these is that you will reduce dramatically the dose of drug in your blood. As a result of that, these examples of inducers, you can see here that basically the recommendations are avoid using these NOACS under these circumstances. The other types of interactions that one can get with drugs is the opposite. So now we're inhibiting the liver enzyme, or we're inhibiting P-glycoprotein, so the net effect will be an increase in your blood concentration and here the actual recommendations are a little bit variable, either no adjustments versus reducing doses in case of dronedarone. This is clarithromycin. You have other antibiotics you can see here as well, rifampin. But generally speaking, when you have these agents which will actually inhibit metabolism of the drug, often there's actually either no adjustment or some adjustments which are recommended to the drug itself. It's not as significant as it is when you induce these enzymes. Okay, with that, I'd like to talk a little bit about coronary disease. And we talked a little bit earlier about what do you do. This slide is just to show you that there's a lot of overlap between AF and coronary disease. Just look at this bottom line. 25% of patients that got into Aristotle, which is the apixaban trial, had a prior PCI. And that's the estimate. About 20-25% of patients who have AF will have concomitant coronary disease. And the question that we see with chronic stable disease, and in fact I think someone asked that question earlier, was, well, do I have to give aspirin? Okay, my patient has AF, so I get it. He should be on anticoagulant. But he's got coronary disease. Should he be treated with aspirin? How confident am I that an anticoagulant alone is going to protect him against coronary events or ischemic events? Okay. Well, the guidelines suggest that a single anticoagulant is sufficient. Now, what's that based on? Well, there's real data in which there's really consensus as to the effect versus less clear data. So here's the clear data part of it, okay? Let's look at warfarin alone, risk of bleeding, 1. If we add aspirin, forget the triple therapy, we'll talk about that this afternoon, but if we look at warfarin plus aspirin, 80% increase in the chances of bleeding. And this has been replicated in multiple studies. If you combine an antiplatelet agent with an anticoagulant, guess what? Your patient has a higher chance of bleeding. And this is very, very strong data overall. Now, what about warfarin? Can you prevent events occurring after MI, for example, which traditionally we give aspirin? Well, this is the WARS-2 trial, and there's a couple of trials that have shown the same thing, but the point of this is a trial post-MI, and what you're seeing are the event rates after the MI on patients randomized to aspirin, randomized to warfarin, or the combination of. And what you can see is that, in fact, there are more events that occur on aspirin than on warfarin. And in fact, if you give both, in fact, you get a little bit more bang for your buck. You get a little more prevention. So how is it then, with data like this, that when if you don't have, these are not patients with AF, by the way, these are patients with coronary disease. Why is it that we give aspirin and we don't give warfarin? Based on this data, we should be probably giving warfarin plus aspirin. Well, the reason is because it bleeds more. And over time, the consensus was that aspirin was a reasonable thing to give instead of warfarin for these patients because the risk of bleeding was just too high with warfarin. And that's why aspirin is the go-to thing. So, but if you're in a situation where you're going to give warfarin anyway because the patient has AF, well, to give aspirin on top of that, you're increasing the risk of bleeding, and you're already giving a drug that's better than aspirin alone. So based on that data, this is the basis of the recommendation that's coming from CCS. And so here we have our patient has a CHADS of 1 or 65 or greater, has stable coronary disease. The recommendation is that an oral anticoagulant alone and no aspirin. Why? Because if you add aspirin, you increase the risk, and it's not clear that you're actually increasing the benefit in that patient. Okay. Now you can come back to me and say, yeah, well, that's really nice, and I can understand that for warfarin, but you're also saying you should be using a NOAC. And how do you know that NOACs do the same thing as warfarin does as secondary prevention? And it's a fair question, and the answer to the question is that at least in the case of rivaroxaban, there is a trial, albeit at a very different dose, a dose of 2.5 milligrams twice a day, which does show efficacy against recurrent ischemic events after MI. And that data doesn't exist for dabigatran, nor does it exist for apixaban. So there is a bit of a stretch in this, but again, it's a risk, the certainty of increasing your risk of bleeding versus the perceived or lack of perceived benefit by adding aspirin in that situation. So that's the basis of that recommendation. So don't give aspirin is what we would recommend. Okay, a couple of comments about cardioversion. I think most people understand the approach. If one decides to cardiovert a patient with warfarin, the recommendations are a minimum of 3 weeks of anticoagulation before the cardioversion versus doing a transesophageal echo just before the cardioversion. However, one of the things that we often see is that the cardioversion gets delayed and delayed because the INRs are never perfect during that lead-in period. Now, about the NOACs, there have been observational trials for the 3 listed here, and in fact, there has been one prospective randomized trial with rivaroxaban. This is the dabigatran data, but the data are very similar for apixaban and rivaroxaban, just as for illustration. So here you have about 1,800 patients over the course of RELY that were cardioverted. And you can see that this is not a randomized comparison, by the way. This is non-randomized. About a quarter of the patients getting dabigatran actually had a TEE, whereas only about 13% of the warfarin patients that got a TEE. But you can see that your chances of finding a clot in TEE are pretty similar. They're on the order of 1.5%, irrespective of the drug. And if you look at the actual stroke rates that occurred during the course of this trial, you can see there's 0.3% versus 0.6% versus 0.8%. So very, very low. Not substantially different from one group to the other, certainly not statistically different from one group to the other. And so it was based on this is that it was felt to be a reasonable thing to do to go ahead and proceed with electrical cardioversions in patients on NOACs. I did mention that there is one randomized trial. This was with rivaroxaban. There was actually 2 phases to this trial. There was an early phase, so these were people who got TEEs. Randomization was between rivaroxaban versus warfarin. There's a delayed arm as well, so these are people who got a minimum of 3 weeks of anticoagulants. And what you see, the primary endpoint after I think this was 42 days, 0.5% in rivaroxaban, 1% of vitamin K. Antagonist, very similar to the data I just showed you, for example, in the observational data, so quite consistent. One thing that was interesting in this trial, though, was that if you look at the number of patients who actually got cardioverted on time, only 36% of patients that were randomized to warfarin actually got their cardioversion when it was supposed to be done, versus 77% on rivaroxaban. Why? It's because of inadequate anticoagulation, INRs that fluctuate. In my own hospital, it's terrible for the patients who come in with warfarin. We have a secretary that reviews all the INRs before she calls the patient in, and it's amazing how often these patients keep getting put off because there's an INR at 1.6 or 1.7, unfortunately. So a conclusion then, for NOACs, it appears to be as safe as warfarin. It's probably a more efficient approach for electrical cardioversion. Obviously, you're worried about adherence, that the patient is compliant with their medication, but you don't have to worry about fluctuation of activity. Transesophageal echo is not a prerequisite, although I know there are some people that prefer to do a TEE in some of these patients. And essentially, the approach is identical to warfarin, 3 weeks beforehand and a minimum of 4 weeks after the cardioversion is recommended, but often these patients will require lifelong lifelong anticoagulation. Okay, now the next topic we'll talk about is prior procedural management of anticoagulation. This basically, you have patients, they're in real life, they have AF, they're on an anticoagulant, but things happen. They need an operation. They go see the dentist. You get calls. I get calls from the dentist. I assume you do too. And then you have a decision to make. Do I stop the anticoagulation? And if I do, how do I do it? And how do I restart it? So the first thing is when you make this decision, am I going to stop or am I not going to stop? Well, if you have a hypothetical situation where you said, my God, this is a very, very high risk of stroke. Guy has a mechanical heart valve, for example. And he's going under a procedure which has very little risk of bleeding. Well, the obvious choice would be, well, I don't think I'm going to stop my anticoagulant. If I balance the risks and the benefits, I have a lot of risk to stopping. I don't have a lot of benefit from stopping. But that's the approach that we have to take. And this is actually coming from the guidelines. This is one of the new things that came out of the 2016 CCS guidelines. So certainly these are all available on the website, by the way, if you want them. So in the case of low risk of bleeding, and here's a couple of examples of procedures where it is felt that it is not necessary to stop the anticoagulation. Dental extractions. Now this is something kind of close to home. My wife's a dentist. And so I discussed this with her, and she looks at me and she says, what do you mean? Are you crazy? Have you ever had to pack a tooth when it's a socket? Anyway, but nonetheless, the guidelines do say that for most dental extractions, they can really treat it adequately with adequate packing of the root. Skin biopsies, cataract surgery, any dermatological procedure, colonoscopies, as long as a biopsy is not performed, these things do not need interruption of anticoagulation. I'll talk a little bit more about pacemakers in a moment, probably more relevant to the cardiologists. Intermediate risk of bleeding. Here we do have to interrupt anticoagulants. So these are more invasive procedures, orthopedic surgery, vascular surgery, for example. And then finally, high risk of bleeding. Anything that comes close to the central nervous system. At one point I had a call and someone needed to get a facet freezing or something and asked me what should I do. I said, geez, if there's a needle close to a nerve root or to a spinal cord, I think you better stop the anticoagulant. Cardiac surgery and so on. And also of note, if you go a colonoscopy with intention to biopsy, the anticoagulant should be stopped. So how do we do this? Well, the recommendations for the NOACS, I won't go through this whole slide, but if we look at the NOACS, if the bleeding risk is considered to be reasonably low, then 1 to 2 days beforehand, in the case of apixaban or rivaroxaban, is recommended. If it's a higher risk procedure, for example, open heart surgery, well then we add a day to that recipe. The Dabigatran is a little bit different. The recommendations are identical if your renal function is normal, but if your renal function is abnormal, well then you add an extra day to the initial recommendation. So creatinine clearance of 30 to 50, add an extra day. Creatinine clearance is less than 30, add 2 days, and I would question about whether or not that patient should be at all on dabigatran. This is just an example of a trial that we did here in Canada. This is called the BRUISE trial that David Burney led out of Ottawa. And these were patients who were actually on warfarin. They needed a pacemaker. And the patients were randomized to either discontinuing warfarin, which was the classic way, like putting them on heparin for bridging, and then restarting warfarin thereafter, versus just leaving them on warfarin, doing the procedure, even despite the fact that they were already anticoagulated. And what you see here is, in fact, there was a dramatic improvement in patient outcome in those patients that remained on warfarin and which were not bridged. The rate of bleeding in this cohort was about 16% in patients who got bridged with heparin. Okay. This is another trial that came out of Hamilton, was published last year, the BRIDGE trial. These are patients for atrial fibrillation. These were randomized to bridging. So in this case, all the anticoagulant in question was stopped, and then the patients were randomized to either a placebo versus low molecular weight heparin. And you can see there were about 900 patients in either arm. And here's the primary outcome. So you say, okay, you've stopped, you haven't bridged, so obviously our worry is they're going to have strokes, or they're going to have clot. But in fact, if you look at the 900 patients that got no bridging, there were only 4 events that occurred. In the group that got bridged, only 3. So there was no differences between these two. So there was no advantage of bridging in this cohort and giving heparin to these patients. However, if you look at the bleeding side, which is shown here, a dramatic improvement in bleeding. People who were not bridged had less than half the rate of major bleeding versus those patients that were bridged with heparin. Heparin, if you give heparin and you somehow have a wound or a cut or something, heparin will bleed 20% of the time. And so as an electrophysiologist that implants devices into patients, I go crazy actually, when I do a device and I find out somebody after put the patient on heparin that night when the patient really doesn't need to be put on heparin whatsoever, either because they're going to start the NOACS the next day or what have you. Okay, so what are the recommendations then for bridging? It's recommended only for patients at high risk of thromboembolic events. So we're talking about CHAD scores of 4 or greater. You used to have 3 in the previous guidelines. Someone who has a mechanical heart valve. Someone who's had a previous stroke in the 3 months preceding their surgery. And then finally, people with rheumatic heart disease. These are the recommendations. And this is the case for warfarin. By the way, these recommendations are for warfarin. When you start, well, I won't go into details, but essentially you start low molecular weight heparin, and then restart obviously the warfarin, and then bridge, and then overlap the heparin and the Coumadin until the patient is therapeutic. In the case of NOACS, however, no bridging is necessary. The half-life of low molecular weight heparin is not that different from the half-life of each of the NOACs. So there is no real advantage of stopping a NOAC and starting on heparin. You may, at best, be gaining several hours of maximum of anticoagulation coverage. So in this case, it's actually much simpler. You stop the NOAC, as we mentioned earlier, 1 or 2 days beforehand, and then you restart once it is feasible to start, depending on hemostasis. Now, this recommendation is based on some of the studies I've already shown you, but here's a couple of more. There was allusion to Orbit AF, which was shown, again, bridging was associated with increased risk of bleeding. There's another trial here, the perioperative dabigatran trial, which came to the same conclusion, and et cetera, et cetera. So the last topic I'm going to talk about this morning is what to do with patients who come in with a stroke and have AF documented. And this is going to be very brief. First of all, AF is documented in approximately 10% of people who present acutely with a stroke. And depending on how aggressive you are at monitoring that patient, and we recommend a minimum of 24 hours of monitoring in patients who have a new stroke, although there are ways to monitor even longer, that can actually rise to 20 or 30% of patients with a stroke if you prolong the monitoring. What is recommended? Well, these are coming actually from the stroke guidelines. These were published a couple of years ago. So these are coming from neurologists by and large. So patients with an acute ischemic stroke with no apparent cause, prolonged rhythm monitoring up to 30 days, these are American guidelines, is reasonable within 6 months of the index event. For most patients with a stroke or TIA in the setting of atrial fibrillation, so if we do find AF, for example, it is reasonable to initiate oral anticoagulation within 14 days after the onset of neurological symptoms, so within 2 weeks. If the patient has a very high risk of hemorrhagic conversion, and that means a very large infarct, someone who already has evidence of hemorrhage on the imaging initially, uncontrolled hypertension, or has a tendency towards hemorrhage, it's reasonable to delay this initiation beyond 14 days. And this is a 2A recommendation. And then finally, we'll hear more about this afternoon, but the usefulness of closure of the L8 appendage with the Watchman device is uncertain, and this is a 2B. And I think there is a lot of debate about the utility of this device, and I think it warrants even further debate. Okay, and then I'm just going to stop by saying, well, which drug should you use? Well, again, if the risk is of hemorrhage after an acute stroke, well, then why not choose an agent which has associated with the lowest hemorrhage, and that would be one of the NOACs, 50% reduction in that risk. So I'll stop there, and there are obviously a lot of other clinical situations we haven't talked about. We'll have a chance to discuss that maybe during the question period or later. Thank you.
I think a lot of you got questions from your patients about the potential relationship between sports and athletic activities and outcomes, and particularly in atrial fibrillation. So there is a context to this. But I thought instead of just only talking about sports and AFib, and there's some stuff to say about that, that we should just sort of review a little bit about sports activity, exercise, and potential risks and benefits with respect to heart disease in general, and then in particular with respect to atrial fibrillation. So questions we often get asked is, what do we need to know? What do we need to tell our patients? And the top left is Arnold Schwarzenegger, who is famous for saying "Yo Fayed." And Abebe Bikila, some of you may remember, ran the Rome Olympics, in bare feet in 2 hours and 15 minutes, having basically not trained in the modern fashion, just kind of ran from home to school and back, and then from home to work and back. He was a policeman, and he just kind of trained in his spare time, and an amazing athlete. So the kinds of questions that we often get asked as caregivers, and we may ask ourselves, and this may be relevant for ourselves and our patients and our family members, is how does the heart adapt to sport? We don't have time to talk about that in great detail, but we'll talk about that briefly. Is sport cardioprotective or cardiotoxic? Under what circumstances is exercise, particularly high volume exercise, potentially risky? If there are risks, how much is too much? And is it everybody or just a few athletes, and can we predict who's at risk? And we won't have time to talk about it, but the question often comes up, do we need to screen our patients, or in fact normal healthy individuals who want to engage in sport, particularly competitive sport, do they need to be screened? The story of sport, of course, goes back, and the story of the potential risk of sport goes back to Sparta, when Phidippides, who was an Athenian herald, ran from Sparta to Athens to say, we won. Just imagine having to run 250 kilometers to say, the Maple Leafs won yesterday. Of course, that happens very rarely, so it doesn't really matter. And he dropped dead after this 240-kilometer run. That's quite a lot of running, but he ran, apparently, if the legend is correct, with his shield and his armor, so hot weather, wearing 40, 50 pounds of metal and bronze, and that's quite a lot of exercise, but allegedly he arrived and said, we are victorious, and then dropped dead. So that's the first recorded, as far as we know, exercise-induced sudden death. And of course, lots of people are worried about this. Just to give you an example of the limits of human endurance, this run has been reproduced by a bunch of individuals who do this every year, started by this British RAF commander, you can see at the bottom. They run 250 kilometers. The champion is Yanis Kouros, who in 1984 ran 240 kilometers in 20 hours and 25 minutes. So just bend your mind around that for a second. That's running essentially 6 marathons continuously without stopping, without sleeping, just sort of eating and drinking as you go along. And the 6 marathons took him 20 hours. That's six back-to-back marathons at roughly 3.5 hours each. It's beyond belief, but that's the limits of human endurance. I'm not recommending that you do that. At least wait till tomorrow. So obviously there's an extraordinary variability of sports activity, from couch potatoes to people who exercise a lot. This is kind of to give us the big picture of what sport activity does with respect to longevity. So this graph on the y-axis is longevity, mortality ratio, is the risk of dying. With the couch potatoes, people who are sedentary and do no exercise, just sort of getting up and going to the fridge and going to work and getting in your car and going back home. On the top left, that's 1.0. And as you go along the x-axis from left to right, this is the reduction in mortality as a function of the amount that you exercise. You can see that there's a nadir of about 0.6, somewhere between 15 and 20 MET hours per week. To give you a sense of it, the next slide will explain it in detail. If you're running for training, let's say you're running at about 8 or 9 METs. If you're walking briskly, it's about 5 or 6 METs. So this is roughly, jogging, if you like, 2 or 3 hours a week, which is a fair amount, but it's not an extraordinary amount. So the kind of exercise we recommend to our patients, which is roughly 2 to 3 hours of moderate to vigorous activity per week, it gets you down to the nadir of survival. And beyond that, there's no further benefit with respect to longevity. You may get in better shape, but you're not going to add more longevity. On the far right, there's relatively few individuals. You can see this is not really a loss of benefit, although it's been debated because the confidence intervals here, but people who exercise to train for races, who may run an hour a day, 7 days a week, don't get extra benefit in terms of mortality. But there's definite relationship, which is not lost at high levels of activity between sedentary individuals and highly active individuals with respect to mortality. And this is even when you control for body weight and smoking. Obviously, the athletes smoke less than others. You control for diabetes and hypertension and other things. Even after all that, the mortality is less in people who exercise regularly. Just to remind ourselves what we mean by this, exercising regularly would be, for example, biking 45 minutes 2 days a week, or running 45 minutes per week total. This is the recommended minimum. This is now sort of ideal amount of exercise, walking 60 minutes a day, running 45 minutes 3 times a week, cycling 60 minutes 5 days a week. And this is pretty high level of exercise, but this gets you as much benefit as you can possibly get from physical activity with respect to longevity. Importantly, this benefit is also true for cancer deaths, not only cardiovascular deaths. This is now 660,000 people followed for 30 or 40 years, so the data is pretty reliable here. You can see that there's a nadir somewhere around 3 times a week, about an hour at a time. So this is kind of recreational exercise, gets you a pretty substantial benefit for cardiovascular death and cancer death, but there's no extra benefit beyond that. Now, how long does it take for the heart to adapt to exercise? It takes remarkably little or short activity. This is a very useful study to help us understand the physiology of exercise, done by the group from Texas. They're looking at cardiac adaptation. They took people who are sedentary, and they persuaded them to train for a marathon. So these are all sedentary. They all agreed to train for a marathon exactly 1 year from now, and they want a very slow graduated program. The first 3 months they would be walking and jogging a little bit. The next 3 months they start running, and they only do this kind of intensive marathon type training between months 9 and 12. So by 6 months, they're doing what we would consider a recreational exercise, aiming towards a marathon. But you can see the LV mass goes up quickly just from jogging a couple of times a week. And then when you start intensively training for a marathon, there's very little extra remodeling. With the right ventricle, there's a little more remodeling when you exercise vigorously for a marathon. But you can see most of the remodeling, so this is physiological hypertrophy, occurs at sort of recreational levels of exercise. You don't have to necessarily be a marathon runner to get beneficial, probably, but beneficial physiological cardiac remodeling, the so-called athlete's heart. Now, the amount of time that you prolong your life by running is actually spent running, for those of you thinking about it. So it's perfectly fine, just have a martini and chill, because you're not going to live longer. It's just going to seem longer, but that's a separate question. All right, so let's talk a little bit about atrial. So exercise is good for you, bottom line, and we can talk about it in the question period if you like. There's only the very, very, very tiny sliver of the population that are ultramarathoners, the kind of people who run the 250 kilometers from Athens to Sparta. Those kinds of individuals might be at risk for adverse effects of sport, but for 99.99% of your patients, it's impossible for them to exercise too much, and they don't have to be Olympic athletes to get health benefits from exercise. Let's talk specifically about atrial fibrillation, where the story is a little more complicated. These are just examples of high-level athletes that are sort of advertised on the internet, and you may have read about them, that all developed atrial fibrillation. They're all elite athletes. They all got atrial fib in their 40s, some of them in their 30s. Most of them, at least Mario Lemieux, for example, ended up with an ablation, got back to sports. Larry Bird had it at the very end of his career. Marty Fish had an ablation and went back to playing tennis. So this is not career-ending necessarily, but it's obviously a big deal. And is this Coincidence, or is there something about being a professional level elite athlete and developing atrial fibrillation? The bottom line is there probably is, but the risk is not as great as has been defined. So there's two kinds of Ironman. There's Steve Prefontaine, who ran himself to death practically, and then this Ironman competition. Those of you who are interested, you can go right ahead. Your spouses will thank you for it. Why should athletes be more prone to atrial fibrillation than people who are not athletes? And the mechanisms are not completely understood. We'll talk about the epidemiology in a minute. But there's animal models, some of which we've established here at the University of Toronto. There's human experimental models that link habitual, high-level, intense exercise. We're talking now about the kind of exercise that your patients who run Ironman, who train an hour a day at full steam, 6-7 days a week. So we're talking about the extreme of exercise. But those individuals tend to have increased vagal tone. As you well know, athletes tend to have slow heart rates. And increased vagal tone is known to predispose to atrial fibrillation experimentally. They tend to have slightly larger right ventricles. We believe that some of them, and this is not entirely understood, develop atrial stretch, atrial dilatation, and potentially atrial fibrosis as a consequence of the repeated cardiac load of intense exercise, and that may or may not lead to more pulmonary vein ectopy, all of which can trigger or maintain atrial fibrillation. This is just lifted from the internet to give you an example of the kinds of exercise we're talking about. This is an individual, Kurt Searvogel, who decided to cycle 75,000 miles in 1 year. That's 3 times around the world, just because he felt like it, because it was Tuesday. And this is 206 miles, 300 kilometers a day of cycling. If you ask my honest opinion, you should have your head examined if you want to do that, but that's what he did. And he started doing this, and it was basically, he was celebrated on the internet as this sort of being the elite of the elite cyclists in North America. And within a couple of weeks of starting this, he says, this is his blog from just over a year ago. My heart rate spiked up to 210, wouldn't come back down to 170. So he went to hospital, they did an ECG, he had atrial fibrillation, they sent him to the heart hospital with a capital H, I don't know why, it's a capital H, and then his heart went back to being normally again, and the question is, what did we do? Why did this happen? Well, maybe because he's cycling 300 kilometers a day, but internet is sort of full of these things, so many of your patients will tell you that they've read that sports causes atrial fibrillation. And the answer is it may be true. I'm just giving you this as an example because I don't think many of your patients are cycling 300 kilometers a day. So it may be true, but it's really the extremes of exercise where you tend to see these kinds of anecdotes. So let's look at some of the data, long-term follow-up data. Most of this comes from Scandinavia because there's lots of people in Scandinavia. This is from a cultural perspective. They've been cross-country skiers and cyclists going back 30, 40 years, well before endurance sport became really popular in North America. The running craze, as you know, started in the 1970s or 1980s, but in Europe, there's been lots of individuals who've been doing high-level endurance exercise for 100 years. So orienteering is a sport where you run around in the woods looking for things. I don't know what, but they do a lot of physical activity. This was published about 20 years ago, and these are orienteers who had an average of 10-year follow-up. They've been doing this for 20 years, most of them, and they had dramatically lower mortality than non-orienteers, but they had 5 times higher risk of lone atrial fibrillation. Mean age of diagnosis was 52. So what your patients are reading is that it is true that this elite chronic endurance exercise activity does increase your risk of atrial fibrillation proportionately by a great deal. So the relative risk is 500%. The absolute risk is 5% in this case. However, what you have to read carefully when you read this literature, because it's all over the sports literature that exercise causes AFib, which is true at these extreme levels, but the important part I've outlined at the bottom is the AFib of all types is not all that different, because athletes tend to have AFib caused by or contributed to by this elite sports activity, but they have less AFib that's caused by the usual hypertension, diabetes, obesity, sleep apnea, because they're slim and they're in good shape. So the overall amount of AFib is not necessarily less. It's they tend to get this other kind of AFib that athletes get, and they don't get the usual AFib from degenerative diseases that most of your patients get. So it's not, the picture's not as bad as you might think it is. This is another study looking at cross-country skiers, and you can see that if you look at all patients, that you have an excess of patients with atrial fibrillation. This is older individuals. This is at age 70, and the AFib tends to be detected a little earlier at age 60, with a mean of 36 years of training. These patients mostly had resting sinus bradycardia. So long-term endurance sport does contribute to increased risk of AFib, usually at ages around 50 to 60, but it's not extremely common. If you look at large cohorts now, this is from the Physicians' Heart Health Study, 17,000 doctors followed almost 20 years, and we look at the risk of developing atrial fibrillation as a function of the amount of exercise. If you exercise 1 or 2 days a week, no signal for increased atrial fib. If you exercise every day, and you are under age 50, then you've got a 1.7 risk ratio, so a 70% relative increase in risk. I can't tell you the absolute increase in risk because it wasn't in the paper, but let's say the absolute risk of atrial fib in an average 60-year-old is about 1.5% per year. In this group, it might be 2 to 2.5% per year as an incidence of new onset AFib in people who exercise every single day. So yes, it is a slightly increased risk. The absolute risk is small and counterbalanced by all the major benefits of exercise. You can tell with my editorial comments here as I'm all in favor of it, even though it is true that daily exercise probably slightly increases your risk of AFib. Looking at it another way, this is the hazard ratio for incident AFib in a very large group of patients published last year. You can see this is about 20,000 patients. If you're a couch potato, here's your risk is arbitrarily 1. And as you exercise more, this is CRF METs. This is the amount of fitness that you have on a stress test. Now we're not looking at how many hours per week you exercise. We're looking at fitness level. The very fit have a risk that's lower than the couch potatoes, but if you adjust it, the very fit also are less likely to smoke and drink and so on and so forth. They lose some of this benefit with respect to lone atrial fibrillation. So exercise is good for you with respect to atrial fibrillation. A lot of exercise, you lose some of that benefit, but then you gain lots of other benefits. Another way to look at it, and this is my last sort of AFib slide, is how much exercise lifetime does it take to get back to your baseline risk? This is from a Spanish group. It just sort of gives you the pictorial view of what I've been talking about. This is sedentary on the left. This is relative risk as a function of exercise. If you're a moderate exerciser, your risk of atrial fibrillation is down. And then eventually at high levels of lifelong exercise, so I've just extrapolated here or estimated, if you exercise 3 hours a week for 20 years, your risk goes back up to, of AFib, goes back up to a sedentary individual. But again, remember, your risk of dying or having cancer is much lower if you're doing this kind of exercise. It's just the risk of AFib is now back to what a sedentary person's risk of AFib would have been. So you will see patients in your practice who are 40, 50-year-olds. We call them mammals. This is middle-aged men in Lycra. So remember that? That's a new diagnosis. So mammals are the kind of guys who usually have a fair bit of money. They're in the top 1% in income, and they own 3 or 4 expensive bicycles, all made of carbon fiber, $5,000 to $15,000 each, and they cycle with their friends on weekends, and they're really avid cyclists because they have nothing else better to do. I should be careful because I tend to do that too, but anyway, that's what they do, and they will come in with atrial fibrillation, and they're perfectly healthy, and they're slim, and they don't smoke, and they're hypertensive, and they will ask you, Doc, this isn't fair, why did I get atrial fibrillation? And the answer is, well, we don't know, but it might have something to do with your sport. I can tell you none of them will stop bicycling, but they just have to recognize it's one of the potential issues, not life-threatening, and you have to work hard to reassure them. I can tell you they're relatively high-maintenance patients. And over time, I think we'll see more and more of these patients because there's a lot of mammals out there. So the bottom line is exercise is beneficial overall. There is dose-related cardiac adaptation to exercise. It can, at extremes, lead to abnormal function. We really don't know if this athlete's heart is adaptive or maladaptive. In my opinion, it's adaptive in about 98% of patients. Abnormal structure and function as opposed to physiological hypertrophy is hard to diagnose. The rest is sort of small print, but just at the bottom, the dose required to confirm harm is very high, higher than just about all your patients will undertake, and restricting exercise to reduce risk is unproven and probably unhelpful. And with that, I'll stop. Thank you very much. Now we have Dr. Talajic back again. You all remember that Wayne Gretzky was once asked, how come you always skate to where the puck is? And he said, I skate to where the puck is going to be. So Dr. Talajic is now going to skate to where the puck is going to be with respect to anticoagulants.
Thank you. So these are the same disclosures. So, yeah, obviously, NOACS have generated a lot of interest, and the major trials have been released, and of course, but there are a whole host of situations which are still under investigations that we alluded to during the different conferences this morning and this afternoon. So I just went for, I just had a look at clinicaltrials.gov to see how many trials are actually ongoing. It's actually there are hundreds of trials that are ongoing right now in different phases. And so what I thought I'd do is just talk a little bit about a couple of these. I won't go in any major detail. I don't want to cover everything, but anyways, at least touch on highlights of some of the clinical questions that are coming up and some of the trials that are underway to be able to answer those questions. So the first one I'm going to talk about one. It's called Brain AF, and this is one that actually we are leading from Montreal, but it is an international study, and it basically is trying to ask the question whether or not a NOAC can be beneficial in otherwise low-risk patients. These are patients who otherwise would not be candidates, AF patients, who would otherwise not be candidates for anticoagulation therapy. Now, the background of this is that although I think we all are aware the relationship between atrial fibrillation and stroke, what's perhaps less known is that there's actually a fairly strong relationship between the occurrence of dementia and neurocognitive dysfunction and the occurrence of atrial fibrillation. And in fact, the relationship between these two is actually more strong in patients who are actually younger than 75 years of age. So here's an example of a meta-analysis in which these are a variety of trials that looked at neurocognitive dysfunction relative to AF with appropriate controls. You can see there's a 34% increase in the occurrence of neurocognitive dysfunction associated with the arrhythmia. Now, one of the things we know is that in the case of atrial fibrillation, people who've never had strokes, if one were to do imaging of their brains on a sort of an ad hoc basis, there's actually a higher incidence of what's termed here silent cerebral ischemia. And now I'm a cardiologist, I'm not a neurologist, but nonetheless, you see arrows here pointing to little areas in which an ischemic event has occurred. These are people who've never had a stroke in their life and have atrial fibrillation. And in fact, the prevalence of these findings is approximately 11-fold higher than those patients who have sinus rhythm but do have dysfunctioning cognitive dysfunction for other reasons. So the hypothesis is that perhaps when you see neurocognitive dysfunction in a patient with atrial fibrillation, that in fact it may be related to ongoing microthromboemboli, which could be causing deterioration. So if that were the case, then an anticoagulant would make sense, and it may be actually useful in reducing the occurrence of this complication, and as in fact, this is the hypothesis of the Brain AF trial. So here the inclusion criteria, age 30 to 60, so they don't meet criteria for anticoagulation, they have to have AF, and then they have the absence of all the CHADS criteria. So these are CHADS 0 patients less than 65 with AF. The randomization is between rivaroxaban, 15 milligrams per day, versus aspirin. The endpoint is a composite endpoint. It's stroke or TIA, or cognitive decline, which is defined here as a decrease in the mini-mental state examination of 5 points, or the new clinical diagnosis of dementia. So this trial is now ongoing. I think we have about 350, 400 patients in the trial already. However, so the first phase is actually going to be finished pretty soon, but the overall trial where we are looking at over 6,000 patients, which would be recruited into this. So we are now in the pilot phase, and this is probably going to go into the main phase in 2017. So now let's talk about another issue, and that's, we touched upon this in the morning about coronary disease. Coronary disease, what do you do with concomitant coronary disease and atrial fibrillation? I think this slide summarizes the problem. The problem is in AF, we know that antiplatelet agents are not very effective in preventing stroke, so that's why the default is an anticoagulant. On the other hand, in someone who receives a coronary stent, anticoagulants are not very effective in preventing stent thrombosis, so therefore the default are antiplatelet agents. And when we have our patient who has both, which we mentioned earlier this morning, approximately a quarter of patients have both, well, then what do? Well, you treat one condition with one agent, you treat the other condition with the other agents, and before you know it, you've got triple therapy. And of course, the problem is increased bleeding in these patients. So what's going on and where can we go with this? Well, a little more background. I already showed you this slide, and I talked to you about warfarin and aspirin. Now I'd like you to show you I'd like you to have a look at triple therapy. And as you can see, there's approximately a 370% increase in bleeding compared to warfarin alone if you take two antiplatelet agents in addition. So again, that's solid data. And it doesn't matter whether you're on warfarin or whether you're on a NOAC. This is data coming from the RELY trial and here you have a warfarin arm, dabigatran arms. But again, as you can see, we just say we take the dabigatran 110, we see dabigatran alone, with aspirin, with triple therapy, you see this progressive increasing in the occurrence of bleeding. The other thing to consider, okay, so that's first fact. Bleeding increases a lot. Second fact, well, what's the risk of stent thrombosis? When we talk about AF and stroke, we're talking about a risk, an annual risk, which is on the order of 3-4% per year, but it's ongoing, it's cumulative. When we put a stent into a coronary artery, the risk is actually much more short-term. So the latest generation of drug-eluting stents, this is the risk of stent thrombosis. And as you can see, it plateaus up by 6 months. And as terms of an absolute number, we're talking about a 0.5% occurrence of drug-eluting stent thrombosis. So that's the magnitude of the problem that the antiplatelet agents are being given for. What changed a lot of the thinking around this was a trial that was published a couple of years ago called the West trial. This was 500, it's a small trial, 573 patients that were on warfarin, that were undergoing PCI, and they were randomized to warfarin plus clopidogrel, so in other words, no aspirin, versus the classic triple therapy. And of course, the idea being that perhaps these patients would bleed less. And sure enough, there was a dramatic decrease in bleeding in those patients who got the warfarin plus clopidogrel alone with no aspirin. But what was interesting is that if you look at death, MI, stroke, there was actually a reduction in these events as well with the clopidogrel along with the warfarin. So in other words, the patients who got triple therapy actually did worse. Not only did they bleed more, but they actually had more deaths, more MIs. Now the problem is it's a small trial. The power, the statistical power to be able to look at some of these endpoints is fairly limited. Here you see the CCS guidelines that were just released a month ago. And I just draw your attention to the right side. So these are patients who have AF. They have a CHAD score of 1 or greater, or 65. Based on data like the West trial that I just showed you, CCS was actually fairly proactive in making these recommendations, I think. But essentially what we recommended was in those patients who undergo an elective PCI, that in fact you should not be putting the patients on triple therapy, and that we were recommending an oral anticoagulant and clopidogrel for 12 months, up to 12 months, and then an oral anticoagulant thereafter. No triple therapy in elective PCI. In patients who have had a non-STEMI or an acute coronary syndrome, who have also had a PCI, so that's over here, the recommendation is somewhat different. What we've recommended here is triple therapy, yes, but to limit it to 3 to 6 months only, not a full year. And as soon as you can get off one of the drugs, hopefully within 3 months, that aspirin be dropped, and that the oral anticoagulant be combined with clopidogrel up to 12 months, and then the oral anticoagulant thereafter. If you come in with acute coronary syndrome, but you don't get a stent, well, if that's the case, then we refer to the same recommendation that we did for PCI electively. 2 agents, anticoagulant plus clopidogrel for 12 months, and then you drop the clopidogrel. So no triple therapy at all for that group. So these are the recommendations that were released a month ago or so. However, we realized that when we released these recommendations, there was a lot of new data that was on its way. So this is just a summary slide of the different trials that are ongoing right now. The different manufacturers are funding these trials for rivaroxaban, the Bigatran, the Pixaban, the Doxaban, and also the one with the warfarin. And in all of these trials, these are trials after PCI with atrial fibrillation, with or without aspirin. So this is just the example of the Pixaban trial. This is ongoing right now. Over 4,000 patients are being recruited, and essentially the patients are being randomized to Pixaban versus warfarin, and then there's a second randomization, aspirin versus placebo, and all of them are going to be getting a P2Y12 inhibitor, which is going to be clopidogrel in the vast majority of people. The one trial, the Pioneer trial, which looked at rivaroxaban, was actually presented 2 weeks ago in New Orleans, and it was published in the New England Journal, so I think it's worthwhile to review this. 2,100 patients with non-valvular AF. They all underwent coronary stenting, and none of them had a prior stroke or TIA or GI bleeding. These patients then were randomized to 3 arms. The first arm, let me start at the bottom, because that's the classic triple therapy. It's warfarin plus aspirin plus clopidogrel. How long they're on was selected by the physician, either 1, 6, or 12 months for the triple therapy. But the idea is once triple therapy ended, they would then go on to warfarin versus aspirin, and the whole thing would end at 12 months after the event. There's a second arm, shown in the middle, which is here you see it's called Atlas-like. It's an ultra-low dose of rivaroxaban, 2.5 milligrams BID, plus clopidogrel, plus aspirin. Now, why 2.5 milligrams BID? Because that's the dose that was found to be effective in patients after acute coronary syndrome in a non-AF trial. So this dose has never been tried in an AF population. So this is called, and the name of that trial was called Atlas, so that's why it's Atlas-like. And then finally, we have the third arm, which is rivaroxaban, 15 milligrams, not 20, but 15 milligrams daily, along with clopidogrel, for 12 months, so no aspirin at all in this arm, and this is like the West trial that I showed you before, and this is actually this is the arm that's being recommended currently in the CCS guidelines. So a total of over 2,000 patients screened, approximately 700 or so patients per group, and here are the clinical characteristics. Just to point out, they're very, very similar. Randomization worked quite well, average age of approximately 70, and you can see that about 20% or so actually had an acute event before the angioplasty occurred. The rest were elective procedures, and you can see a drug-eluting stent was used about 2/3 of the patients. Well, here's the primary result. So this is the triple therapy arm. So this is warfarin plus 2 antiplatelet agents, and as you can see, cumulatively by 1 year, 27% of the patients had a clinically significant bleeding event. This is now the ultra-low dose rivaroxaban, 2.5 milligrams twice a day, plus 2 additional antiplatelet agents. Strikingly lower bleeding rates. And then if we look at the West-like, we see, again, dramatically lower bleeding. This is the rivaroxaban, 15 milligrams plus the clopidogrel. And so globally, you can see that these two arms are actually quite similar, but both are actually superior then to warfarin along with 2 antiplatelet agents. So now, that's well and good. The primary endpoint's been met. They don't bleed as often. The question, of course, we have is, well, what about, we're giving these drugs to prevent stroke, so what happened there? And unfortunately, this trial is not powered this is not a replication of the entire ROCKET program, for example. But nonetheless, it's reassuring to see that the event rates for the 3 arms were actually very, very similar, approximately 6%, and so that there were no actual statistical differences. The problem is, please note, though, that there are fairly wide confidence limits, at 95% confidence limits for both of the experimental arms, but nonetheless, somewhat reassuring. We will have more data for the other drugs as the next couple of years. This is additional data, all-cause hospitalization for the 3 arms. Again, quite reassuring. You see significantly lower hospitalization rates with the Riva arms, either the 15 milligrams or the 2.5 BID. So the conclusion for this study was that among stented patients, administration of Riva 15 plus clopidogrel monotherapy for 1 year, or the low dose 2.5 BID, along with 1, 6, or 12 months of dual antiplatelets reduced the risk of clinically significant bleeding as compared to standard of care, and it yielded comparable efficacy with broad confidence intervals, meaning that we can't be certain about that. So just to stop there for a moment, so where are we today? I think what happens is that this result is actually fairly gratifying. It's quite consistent with the new CCS guidelines. And basically what we're trying to say is that we should be moving away from taking care of patients with triple therapy. So when the patient has concomitant coronary disease and has atrial fibrillation, two messages. If you're going to put the patient, unfortunately, at a risk of higher bleeding, well, I would argue that you should probably use the anticoagulant that has the lowest bleeding. And we talked about that this morning. So this is generally going to be a NOAC, and it's probably going to be one of the agents that I mentioned earlier that's been shown to have significantly lower bleeding versus warfarin. That would be the first thing. The second point there is avoid the combination of triple therapy for as much as you can. So if you're stuck in a situation where the patient just had acute coronary syndrome, had received a drug-eluting stent, well, you're going to be forced to give triple therapy for at least a period of time, probably 3 months is adequate. I can tell you at the guidelines committee there was considerable debate, and what drove this to at least include triple therapy for at least 3 months was really the input by our colleagues in interventional cardiology. They're obviously very married to antiplatelet agents, but this was done in accordance with their committee on antiplatelets after stenting and acute coronary syndrome. And then finally, try to limit the use of aspirin or clopidogrel along with your anticoagulant for a maximum of 12 months. Once that period is over, you go down to an oral anticoagulant alone. Okay, so I'm going to change gears a little bit now and talk about renal failure. This is just to remind you that of the drugs, the bigatran is the one you got to be careful about in renal insufficiency because it's excreted 80% of it by the kidneys, where the others there's a much lower proportion. And this was alluded to this morning, but here's some data. When you do observational studies and you look in databases about people with AF and warfarin or warfarin, in almost every situation you will find that people who get warfarin, who have AF in an administrative database, always have better outcomes, except one area, and that's here. In databases, and I'm just showing you one study, but this has been replicated in multiple studies, patients who are on dialysis with AF who are on warfarin fare poorly compared to patients who are not on warfarin. And it was as a result of this, CCS made a recommendation in 2014, and just look at the middle paragraph. We suggest that such patients not routinely receive an anticoagulant or aspirin for stroke prevention in AF. So there's a category of patients who actually do worse on anticoagulants. Now, things have changed a little bit. A couple of years ago, the FDA approved apixaban in end-stage renal disease. So in the United States, you can actually give apixaban 5 milligrams BID in dialysis patients, although in Canada, we keep saying over and over again that it's contraindicated. And here's a statement by the FDA. Clinical efficacy and safety studies of Eliquis did not enroll patients with ESRD and dialysis. That's true. In patients maintained on intermittent hemodialysis, administration of Eliquis at the usual recommended dose, that's 5 BID, will result in concentrations of apixaban and pharmacodynamic activity similar to those observed in the Aristotle study. It is not known whether these concentrations will lead to similar stroke reduction. Nonetheless, it is approved in the United States, 5 BID. It's all based on, I think, a study with less than 10 patients in which the drug was given one shot, and then they measured the drug concentrations thereafter. It's look, it's very similar to what you get in people without dialysis. So it's really on pretty thin data, but nonetheless, I do think that there will be a lot, I do think I know, there's a lot of interest about whether or not some of these drugs can be used in renal failure. So there are a lot of studies that are ongoing right now. I'm just going to show you one. This is called the Renal AF trial. So this is a prospective, randomized, open-label trial in patients that have AF who are on dialysis. And they're randomized to apixaban or warfarin. And basically the primary outcome is the onset of first major bleeding, and they're also measuring stroke, mortality, and adherence. as well. So I'm not sure that there are a variety of trials actually going on right now that are looking at these drugs in renal failure, and I suspect that within the next couple of years that perhaps renal failure per se may no longer be a contraindication for some of these drugs. Another clinical problem, therefore another clinical trial. The problem of subclinical AF. Here, this is an electrogram coming from a patient who has a pacemaker. Comes in, how are you doing, sir? Doing great. You look at the memory in the pacemaker, and you say, oh, he has episodes of atrial fibrillation. That's what you're seeing here. This is the atrial channel, this is the ventricular channel. And the question is, what do you do with this? Well, the best data we have up until now came from the ASSERT trial. This is one that was run out of McMaster. And what they showed in that trial is that if you have 6 minutes of what I just showed you, 6 minutes of AF as detected by the pacemaker in the first 3 months after getting your pacemaker, your risk of having a stroke thereafter was increased by 2.5-fold. Pretty impressive. So I guess the argument would be, well, maybe they should all be on anticoagulants. Problem with that is that if you look at the occurrence of stroke in this trial, so the vertical line that you see there is actually the timing of the stroke. The red is actually when the AF occurred. So here you see AF here and then nothing for days, months until the stroke occurred. In some cases, the AF occurred after the stroke. So the relationship between the occurrence, it's not like, oh, I'm an AF, oh, now I got my clot, oh, now I got my stroke. The relationship, there's a statistical relationship, that's for sure, but the timing is all over the place. The other thing about this as well is that the actual expected stroke rates based on CHADS were actually lower than your regular patients that have AF. So it's not quite clear that anticoagulation will change this. So here's the recommendations from CCS. Notice we don't say we recommend, we say we suggest that it's reasonable for someone who's over 65, who has a CHADS score of 1, who has episodes of AF lasting at least 24 hours. I think most people, if you have 24 hours of AF on your electrogram in the pacemaker, we would all probably give an anticoagulant. And then this is the notwithstanding clause, very Canadian, for shorter episodes who have high-risk patients, for someone, for example, who had 12 hours or 6 hours of AF, who's had a previous stroke, then a lot of us would probably give an anticoagulant. So what do you do with 6 minutes? Well, this is just all that to introduce the Artesia trial. This is being run at Hamilton. It's, I think, in many centers across Canada. So these are patients who have subclinical AF, so at least one episode of more than 6 minutes, but none more than 24 hours, who had CHADS VAS score of at least 3. And these patients are then being randomized to aspirin versus apixaban. So this trial is ongoing. I believe there are several hundred patients already in the trial. So if you're in a center that has these types of patients, please put them into the trial. So that's Artesia. The last one I'm going to talk about is the Navigate ESIS trial. So this is a trial that evaluates the role of anticoagulation in cryptogenic stroke. So just a background slide to show that ischemic stroke can be identified and the recognized cause can be identified in a certain proportion, but you're left with about a quarter of patients in which you don't know why the stroke occurred. And ESIS is referred to as embolic stroke of unknown source, or used to be called cryptogenic. Now here's a slide that shows that many of these things are actually caused by clot. So you see examples of a clot trapped in a foramina valley. This one's in a carotid artery plaque, a thrombus removed from aortic arch. These are potential causes of this syndrome. And the trial itself is trying to see whether or not rivaroxaban can reduce the risk versus aspirin in these patients. So here's the actual trial design. So these are patients who have an ischemic stroke in which you've excluded a lacunar stroke, have no significant carotid artery stenosis, no AF after at least 24 hours of monitoring, no intracardiac thrombus, and then they are randomized to rivaroxaban 15 milligrams a day versus aspirin. And the idea is to enroll over 2 years and an additional year of follow-up. So this trial is also ongoing, and this will be a couple of years before. This is a 7,000 patient trial, so it'll be a couple of years before you have the answer to that. And the primary outcome is the occurrence of recurrent stroke. And with that, I'll stop. So there's a lot of stuff going on, a lot of clinical situations. We don't have the data to answer the questions appropriately, and so presumably, hopefully, we will move forward as time goes on. Thank you.
Thank you, Mario. So that's where the puck is going to be. Now we have our co-chair, Dr. Verma, professor of medicine at U of T and a cardiac surgeon here at St. Mike's. And he's going to talk to us about anticoagulation for valve disease. Obviously, the most appropriate individual since he implants these valves and will tell us what to do.
Great. So good afternoon to all of you. It's my great pleasure to address this topic that often is one of the most commonly asked questions: can NOACS or DOACS be used in patients with valvular atrial fibrillation? These are my disclosures. I've received consulting fees, speaking, and research support from various pharmaceutical companies listed here. So I can really summarize my lecture by saying the following, and that is that the bottom line is yes, you can, maybe not, and in some cases, no. And I think that sort of really summarizes the current understanding of where we can and can't use NOACS in this area, but I'll obviously go through some of the nuances in the next sort of 4 points. So I have 4 important points to cover. This is the first point, and that is that valvular heart disease is common in the context of atrial fibrillation. These are data from Gregory Lipp, published in the European Heart Journal, subjournal Europace, and it really is an evaluation of registries of atrial fibrillation across 9 European countries, approximately 3,000 patients, and it reminds us that valvular abnormalities coexist in a very high number of patients who have atrial fibrillation. So clearly, valvular heart disease is common in the context of atrial fibrillation. We also understand the pathophysiology, and that is that various valvular lesions, whether it's aortic stenosis or aortic regurgitation or mitral stenosis and mitral regurg, at the end of the day, they increase left atrial pressure, which in turn leads to progressive atrial dilatation, atrial fibrosis, and remodeling that then in turn triggers or incites atrial fibrillation in this population. So along the first point, not only is valvular heart disease common in the setting of AF, the presence of valvular heart disease actually increases overall rates of stroke and overall rates of death in this population. And this is one analysis from Maurice Serrano's group, published in JACC many years ago, that looks at not the usual culprit, i.e. rheumatic mitral stenosis, but at mitral valve prolapse and myxomatous mitral valve degeneration, and reminds us that individuals who have atrial fibrillation in the setting of mitral valve prolapse also have a significantly higher rate of long-term stroke, but they also have worse morbidity and mortality long-term, with hazard ratios anywhere between 2 to 3 in this population. So moving on, now that we've sort of defined the fact that the problem is common, and the problem even outside of rheumatic mitral stenosis offers poor prognosis, the second point to address is that the definitions of valvular and non-valvular atrial fibrillation are completely misleading, and maybe even the term valvular AF or non-valvular AF is a misnomer. So there is considerable heterogeneity in the definition of non-valvular atrial fibrillation. Non-valvular atrial fibrillation versus valvular atrial fibrillation are simply terms used to identify whether or not a direct oral anticoagulant or a NOAC can be used or not, and therefore they are less helpful across the spectrum of native and prosthetic valve disease. There are various guidelines from various associations that define valvular and non-valvular atrial fibrillation slightly differently. This is the one definition which actually states the absence of mechanical prosthetic heart valve or absence of moderate to severe mitral stenosis, usually rheumatic in origin. I think that's probably the most commonly and widely accepted. The CCS atrial fibrillation guidelines actually state valvular atrial fibrillation as being rheumatic mitral stenosis, mitral valve repair, mechanical or bioprosthetic heart valve. And then the most recent consensus document from these various sort of international societies, if I may, have said the following. This is the latest I could find, and that is that AF in the absence of prosthetic heart valves or hemodynamically significant valve disease referring to a valve lesion severe enough to warrant surgical or percutaneous intervention, or a lesion that would have an impact on survival or well-being. So what does this all mean? If you can't explain it simply, you probably don't understand it well enough. And I think the fact that there's 5 or 6 different definitions speaks to the fact that, you know, we don't have clear and concise data in this space. So from a surgical perspective, this is my very simplistic summary of point number 2, and that is that mechanical heart valves and more than moderate rheumatic mitral stenosis, as shown up here, are probably best defined as patients who have valvular atrial fibrillation. The rest remain a gray area. Now, this paper was published just a few days ago in JAHA, and it actually reminds us that some of the uncertainties around valvular heart disease and where we can and can't use these therapies are in part due to the fact that various trials, although were pretty robust in excluding patients with mechanical heart valves and moderate to severe rheumatic mitral stenosis, invariably included patients with all sorts of other kinds of less severe valvular abnormalities, degenerative valvular abnormalities. Some had bioprosthetic valves, and a result of having this sort of heterogeneous population, there was an opportunity to look at each and individual trial to evaluate whether those so-called more common types of valve lesions were actually safe or effective when NOACS therapy was tested in the context of either the ROCKET trial, RELY, Aristotle, ENGAGE AF, or Averroes. So the third point to make here is that despite the fact that we don't have definitive data in this very large cohort of patients with valvular heart disease outside of mechanical and moderate to severe MS, all pivotal trials did include a large proportion of patients outside of this. These data are not definitive, but they are now available. And let me just review the subgroup of patients with valvular heart disease from these 4 large trials, 3 shown here, and I'll show you ENGAGE AF that was just presented at the ACC this year. So as you can see, in the Aristotle trial, large proportion of patients had at least moderate valvular heart disease, so about 4,000 patients. Same sort of proportion of patients in RELY and a large proportion in ROCKET as well. So the prevalence of sort of valvular heart disease of at least moderate intensity, excluding severe MS and mechanical valves, is actually quite high in this population. And the predominant lesion set is mitral regurg, followed by tricuspid regurg. And most of you, as primary care physicians, will recognize echo after echo after echo that you see in your office has some degree of, degenerative mitral valve, so some degree of degenerative valve lesion, and you're always wondering whether those patients in the context of AF can be anticoagulated or not. So Andrew Ha actually just published this paper 2 days ago, summarizing some of these data from Aristotle, ROCKET AF, and RELY. And basically it is a review paper looking at the subgroup analyses of patients with valvular heart disease within the context of these 3 trials. And essentially what you do see in Aristotle is, again with apixaban, rates of stroke and systemic embolization in this 4,000 subgroup of patients who had significant valvular heart disease. All of the point estimates were either neutral in terms of safe, but clearly bleeding was on the right side of favoring apixaban, suggesting that at least in this context, there was an equivalent efficacy outcome, but a superior bleeding outcome in this population. Similar data was seen with RELY, i.e. safe, and then more efficacious with respect to intracranial bleeding. And when you looked at ROCKET AF, again, neutral with respect to efficacy outcomes versus warfarin. There was a slightly higher risk of major bleed in the context of this trial, and that obviously may reflect differences in background therapy. So again, along the lines of the third point, that these sub-analyses of various NOACS trials do tell a different story. One is that patients with valvular heart disease in the context of these large pivotal trials were older, they had more comorbidities. In ROCKET-AF and RELY, rates of stroke were similar between patients with valvular heart disease compared to those who did not have valvular heart disease, but in Aristotle, the rates of strokes and systemic embolization were higher. Major bleeds were higher in patients with valvular heart disease across all three trials, and that is a reflection of greater comorbidities in this population. Another very intriguing point that is not discussed, but I think is worth some attention, is the fact that within ROCKET-AF, a subgroup of patients who had aortic stenosis had a twofold higher rate of stroke or systemic embolization or vascular death and a 60% higher rate of bleeds compared to those who had AI or MR. But overall, taken together with all of the limitations of these being subgroup analyses of trials with variable definitions of valvular heart disease, they do suggest that outside of mechanical valves and outside of severe rheumatic MS, apixaban, dabigatran, rivaroxaban are appropriate choices and can be used in this population. So what about edoxaban? These data are not published yet, but I think are imminent, and these are from the ENGAGE-AF TIMI 48 trial, and again, they demonstrate that edoxaban in the subgroup of population of patients with valvular heart disease outside of the two that I mentioned was safe, effective, and net benefit favored the use of edoxaban. So the fourth point, what do we do with mechanical valves? Fewer mechanical valves are being implanted compared to what they used to be in the past. More people are choosing bioprosthetic valves even at younger ages. But if you do put in a mechanical valve, aortic or mitral, what should be done? And John Eichelboom led this study. We actually recruited into this study called the Realign study that actually was stopped earlier. It was stopped earlier because of higher rates of thrombosis and major bleeds. The mechanisms are not clear, but what is clear is that NOACS should not be used in patients who have mechanical valves until further data are available. Now, not all mechanical valves are made the same, and there are some intriguing data with this Onyx valve, which is supposed to be the fourth generation aortic valve. We don't have any experience at St. Mike's with it. We don't have it on the shelf at this point, but the available data suggests that these are less thrombogenic and may be still treated with Coumadin, but to a lower target INR. So whether this is a population to go after with NOACS remains unclear. So what about bioprosthetic valves? And like all things in medicine, most things are gray. And just like it's hard to figure out if the cat is going up or down in this picture, the same applies to the bioprosthetic valve discussion. You know, can we or can we not use a NOAC in this population? So in general terms, as most of you know, cow and pig valves are less thrombogenic compared to mechanical valves, and long-term anticoagulation is deemed unnecessary in these patients except for aspirin. There is an increased risk of thrombosis short-term, and therefore people who put a mitral cow or pig valve usually will recommend as a 2B indication the use of warfarin for 3 months, but that too is not universally done. There are some small case studies demonstrating the safety of NOACS or DOACs in this population, but there is really no definitive data to guide the practice of whether these strategies can or cannot be employed in this setting. So the current guidelines suggest that if you do embark on anticoagulation of a tissue valve, which most likely will be a tissue mitral valve, for the first 3 months use warfarin, and then if you want to substitute with a NOAC, you could do that. And that's just based on sort of general consensus about risk of thrombosis early, and the previous, I think people are colored by the Realign data and what that might have shown. But another problem is emerging, friends, and this has just come to the limelight in the last year or so, and that is that, you know, on the right-hand side, we understand that tissue valves degenerate over time, but what is becoming apparent is that early on, there may be changes in tissue valves with respect to thrombosis, and in fact, short-term leaflet motion abnormalities may emerge in tissue valves that may be treatable with anticoagulation. And this is not just with surgically implanted aortic valves, this is also being seen across the spectrum of patients with TAVRs, or transcatheter aortic valves. And these are being mostly generated from smaller studies and case series, but have led to a lot of interest into developing an understanding of whether early short-term anticoagulation after an aortic valve has been implanted can prevent abnormal leaflet motion and prevent leaflet thrombosis. So we are about to embark on a study called ACHIEVE, which is actually going to take bioprosthetic surgically implanted valves. They'll be randomized to warfarin versus aspirin, and this is a study that we will be doing with Philippe Pibarot, and in fact this is a trial where significant abnormalities, leaflet motion abnormality, will be evaluated at 3 months with TE and with the help of 4D CT. So on the horizon are also other sort of strategies. There's a small study looking at surgical AVR versus aspirin versus warfarin in TAVI patients. Then there's the Galileo sub-study and Galileo 4D that will randomize 300 patients undergoing TAVI to rivaroxaban versus aspirin, 4D CT. And then there's the Rhetoric trial that will look at 200 patients undergoing TAVI randomized to warfarin, vitamin K antagonist, whose the name of which I can't really pronounce, versus standard of care. So finally, friends, in the last minute, what about rheumatic mitral stenosis? And again, there are limited data to guide decision-making, and the data for AF burden and thrombosis is driven by older data. The use of a NOAC, however, think about this, could be extremely valuable in this population because they're often disadvantaged because of socioeconomic barriers and can't use warfarin appropriately. And there is so much data from developing worlds where this problem exists that TTR that you think about and dream about as trialists around the table, look at the TTR achieved in those worlds where people can't really control, warfarin appropriately. It would be great if there was a strategy that was simple and easy to use where you didn't have to measure, INR levels and could get durable control in a population that can't use warfarin appropriately. So Dr. Youssef and Dr. Connolly are leading this Invictus program, which is the largest rheumatic heart disease program, and it will test the use of rivaroxaban in this population. It has a non-inferiority design to test rivaroxaban, non-inferiority to warfarin in about 4,500 patients with atrial fibrillation and at least one major stroke risk factor. And it also has a superiority arm to compare rivaroxaban with aspirin in 2,000, rheumatic heart valve disease patients with AF who are unsuitable for warfarin, or those without AF but have risk factors for thromboembolism. So how do we put this all together? What's the bottom line? I think the bottom line is that we look at expert opinion in the absence of having definitive data for most of these areas. And in the CCS atrial fibrillation update from published last year, because there is a lack of data, all of the primary and secondary panelists, which I happen to be one, were asked by the chairs to provide to vote, essentially, and provide an expert opinion in terms of a survey of where they would think a NOAC is contraindicated and where they would think it is indicated. So as you would expect, NOAC use is contraindicated. Most experts on the primary and secondary panel thought mechanical heart valves and rheumatic or non-rheumatic mitral stenosis, but where they thought it was reasonable was really across a spectrum of where there is currently gray data, including bioprosthetic heart valves, where 82% of the primary and secondary panelists thought in the aortic position that would be reasonable, and 2/3 agreed that in the mitral position that would also be acceptable. Mitral valve repair was also considered to be acceptable, as was mild to moderate severe mitral regurgitation. So really, I think the two areas that most practitioners here need to take home are these two, and that is that in those patients, don't use it, but for the rest of the patients, it is quite reasonable. And this is my last slide. Again, it looks at a European recent guideline document summarizing issues around valvular indications and contraindications, and essentially says the same thing, that these are the contraindications. The rest actually are areas where most experts and guideline writers agree. There are some nuances around timing of intervention, strength of intervention, but in general, they are not contraindications per se. So with that, I'll end with this famous quote: all truths are easy to understand once they're discovered. The point is to discover them, and I think that you've learned from today's program, many of the experts who spoke today, that the story is not over. There's many more trials that are forthcoming and many more areas that we will be addressing. So with that, it's my great pleasure to introduce my colleague and friend, Dr. Neil Pham. And Neil is a interventional cardiologist at St. Michael's Hospital. He's also the director of the coronary cath lab. He's an outstanding interventionalist and clinician, and is also doing some great work with structural heart disease. He's running the mitral clip program, and is also now actively involved in the percutaneous left atrial appendage closure program. And we've asked Neil to tell us, my patient is bleeding on a NOAC. Can we get rid of all of the anticoagulants and just deal with stroke prevention through an interventionalist lens with left atrial appendage closure? So welcome, Neil.
It may be a bit daunting to be the sole interventionalist here in a talk, mainly in a symposium mainly about medical therapy, but as far as conflicts of interest, I like to do procedures, but I view myself as a clinician first, and I think that if we choose the right treatment in the right patient, we'll achieve the best outcomes. So we're going to talk about stroke versus bleeding, because this is really the dilemma that all of you guys taking care of patients has to face. Briefly look at evidence for anticoagulation, introduce left atrial appendage closure, and then discuss from a practical point of view who you might consider in your practice for this procedure. So this is a patient we treated recently, and I think this is the type of guy you might consider. It's a 78-year-old man who has persistent atrial fibrillation. His CHAS2-VASc score is 6. He's extremely high risk for stroke, and he's had a previous stroke. And his problem is recurrent GI bleeding due to angiodysplasia, such that he really is intolerant of warfarin. He's tried all 3 NOACs. He continues to bleed, such that his family doctor had him adjust on a baby aspirin. He's had coronary disease, he's had stenting, he's had heart failure. He pretty much is a high-risk patient. So this is my only question for the group, and we'll take a show of hands. If you have this patient in your practice and you're worried about stroke, what would you do? Would you continue aspirin alone, hope for the best? Show of hands. Would you add Plavix to aspirin? Would you try low dose apixaban? Okay, a few hands there. I think that's a popular choice. Would you consider referral for a procedure to close off his left atrial appendage? Well, about the same as apixaban. What's that? Prayer. Hope for the best. That was the top one, yeah. Okay, so I'm not going to talk about things you've already heard. CHAS-VASc score helps to distinguish people at risk for stroke. Has bled score really identifies people at risk for bleeding. But really, these two things go together. The highest risk patients have high risk of stroke and a high risk of bleeding, and these are the patients that all the subspecialists probably don't even see and that the family physicians are managing. So, stroke prevention in AF, we know that warfarin and NOACS reduce the risk of stroke, ischemic stroke, somewhere between 60 to 80%, and the NOACS were invented really to be safer, mainly because they have less bleeding, particularly intracranial bleeding, which is the main downside of all forms of anticoagulation. The problem in the real-world practice is that patients don't like taking medications. There are either contraindications to these drugs in a quarter of patients, or there's problems with compliance or adherence, drug interactions, such that a lot of patients are not even offered the drugs, or they're on them for a short time and they come off of them. So if we look at the studies, what was the adherence, what was the rate of drug discontinuation? In all of the NOAC trials, that's around 25% of patients had to discontinue the drug for whatever reason. And that's in a randomized trial where we cherry pick the patients. In the real world, it's higher. And then the rate of major bleeding was somewhere between 2 and 3% per year. So it's a real problem. So if we look in registry data, which provides more of a snapshot of what's happening in practice, the compliance with warfarin, it's quite poor. It's about 50% in this study after 2 years of follow-up, and with NOACS, it's about 30% after 2 years of follow-up. And I don't know if this mirrors what people see in their own practice. So, as Subodh very nicely pointed out, the problem is different whether you have valvular or non-valvular AFib. So, we know that in valvular AFib, like for example, someone has mitral stenosis, the clot is not only coming from the left atrial appendage, it's also coming from the left atrium itself. And so, considering a local therapy in someone who has valvular AF doesn't make a lot of sense. That's why they get systemically anticoagulated. However, in non-valvular AF, we know that more than 90% of the strokes are due to clots forming left atrial appendage, as shown in this TE on the right-hand side. So that's where the whole concept of left atrial appendage closure comes from. If you can put in a device which basically seals off the orifice of the appendage and blood cannot get in there to clot, then you basically reduce the risk of stroke, and they no longer need to take anticoagulants, so therefore you reduce the risk of bleeding. It sounds great. The only downside is they need an invasive procedure. So these are the two left atrial appendage closure devices that are approved for use in Canada. The one on the left is called the Amplatzer cardiac plug, which kind of looks like a pacifier. It has an anchor which sits inside the appendage, and then it has a disc on the outside to completely seal off the orifice. And then the right-hand side is the Watchman device, which some people think looks like a half football. So these are both available in Canada. There have been a whole host of randomized trials comparing left atrial appendage closure devices to anticoagulation. You've probably seen these in the literature. The main study using the Watchman device was called PROTECT AF. It has the longest follow-up. So this was a randomized trial of the Watchman device against warfarin. And in this 4-year follow-up here, you can see that there are significant reductions in stroke, which is a combination of ischemic and hemorrhagic stroke. The ischemic strokes are probably slightly less in the warfarin arm, but the hemorrhagic strokes are dramatically reduced in the device arm because they're not taking blood thinners, and therefore they can't really have an intracranial bleed, at least not as frequently as if they were taking warfarin. And then if you look at all that, and then just look at all-cause mortality at the end, it's reduced by about 60% in the device arm, mainly because if you have intracranial bleed, the mortality is about 60 to 70%. So if you can avoid that, it's safer. Now, as I mentioned before, it's an invasive procedure. What's involved with this is it's a venous puncture in their leg. We pass catheters up to the heart. We use transesophageal echo to do a transseptal puncture, get onto the left side of the heart, and then very carefully install this closure device. The whole procedure takes about an hour to hour and a half. The patient is under general anesthesia, so they don't feel any of this. After the procedure, they're woken up from the cath lab. They go monitored overnight in the ward and go home the next day. But the main risk of this procedure is causing a pericardial effusion, and most of that can be dealt with percutaneously. In this trial experience, which I would say, taking relatively inexperienced operators and doing these procedures, there was a learning curve, and the rate of pericardial effusion fell over the course of the study. So this was published in JAMA a couple of years ago, just looking at the cardiac mortality and all-cause mortality, and you can see both were in favor of the device over warfarin. There have been no trials comparing left atrial closure devices to NOACS, and those are underway. So this is really how these devices reduce mortality, as they avoid this, which is the intracranial bleed. And this is just a relative comparison looking at the reduction in all-cause mortality against warfarin, all the NOAC trials on the left, and then the appendage closure trial that I mentioned here on the right. And it's mainly because you don't get the intracranial hemorrhage that you have the improved mortality. So the Amplatzer cardiac plug has similar data from registries as far as efficacy and safety, and many of us think it may be more effective than the Watchman because of its design, and there is now a randomized trial comparing this device to the Watchman, which we'll be part of. So from a practical point of view, who should you consider for this procedure? I think if they have high risk of stroke and they've had recurrent bleeding, either GI, GU, or certainly a intracranial hemorrhage such that patients just on aspirin, they've seen a neurologist, a neurosurgeon, they're quite reluctant to consider reintroduction of anticoagulation. I think these are the patients that we believe will help, and these are certainly the patients that we treat. A less frequent indication would be those who have recurrent embolism despite anticoagulation, but those are less common. So let's go back to that case, the 78-year-old man who's on aspirin. So he was referred for left atrial appendage closure just before the holidays last year, and then, unfortunately, on Boxing Day, he had a stroke. He went into the hospital at St. Mike's, he was admitted under internal medicine, and he was discharged home on aspirin and Plavix, which, as you guys recall, was one of the choices. I came back in early January and found out this had happened to him, and was quite alarmed, so I called him up, and we admitted him, because we suspected that he had a clot in his appendage, and so he had a TE, which unfortunately shows a large mobile thrombus in his left atrial appendage. So we kind of bit the bullet, gave him high-dose heparin for 3 days. He didn't bleed, and that was enough to dissolve this clot, and then we did the appendage closure right after that. So most people view left atrial appendage closure as a preventative therapy. Prevention is less sexy than treatment, but this case sort of highlights that these patients who are at high risk, they do have strokes if they're left just on aspirin. So this is how the closure device looks. You can see here that there's this disc which completely seals off the orifice, and then there's an anchor device that sits within the appendage itself. And here's a 3D echo, which is looking en face at the device, sort of circular disc here, completely sealing off the orifice of the appendage, and the mitral annulus is down there. So he's now had almost a year of follow-up. He made a fairly good recovery from his initial small stroke. He's had no recurrence of TIA or stroke. He's living independently, and he's just on a baby aspirin at this time, and he's not having any GI bleeding. So St. Mike's program is a nice collaboration between interventional cardiology, EP, and echo. The process is that I see these patients in the clinic. We have a discussion with the group. They have a screening esophageal echo to make sure they're a candidate, and about 90% of patients anatomically are candidates. They then have their procedure, which involves 1 night in hospital. And at 6 weeks, we repeat their TE to make sure we have a good seal of their appendage. There's no clot or anything like that, and if that's the case, we drop the Plavix and they just remain on aspirin. Now, we have had patients who had recurrent intracranial hemorrhages where we've just done these procedures on aspirin and no dual antiplatelet at all. And the advantage of this is there's not a need for any warfarin or NOAC. Anticoagulation is not part of the mix. So to conclude, left atrial appendage closure is a good alternative for high-risk AF patients for stroke prevention who have recurrent bleeding on NOACs. And future studies comparing left atrial appendage closure to NOACs or closure devices themselves will help to further refine their role. So you can really view this as a very niche treatment for your patients who really don't have any other options, who failed multiple NOACS. And with that, I'll close.